So the format we won't go through as we already go through multiple times. But I just want to highlight that in real exam as well as in this is a virtual practice that sometimes your examination can be quite fast because it's yes no question. But in real life, please give yourself about 3 to 4 minutes to examine the patient. Take your time. Okay. So with that, I think Ben, you will start with the first case. I will start the timer. I'll give you 4 minutes instead of 5 minutes. Your time will start now. Okay, time's up. So this is the patient, Mr. Richard. You can start now. Hello, Dr. Ben.
Sorry, I mute my mic just now.
Okay, all right. You can. I will reset the timer. Okay, let's start.
Okay, hi. Hi, good afternoon. I'm Chia, one of the doctors in this clinic today. Am I speaking to Mr. Richard, 50 years of age?
Yeah, I'm Richard.
Hi, I'm nice to meet you. Today we are going to discuss about your health condition as I received a letter from your GP stating that you have some hand numbness. Could you tell me more about that?
Yeah, doctor. I realized that I have numbness all over my fingers and also my hand. Almost for the past 3 months now. It's getting worse. Usually over all my fingers, but I feel like my little finger and the fourth finger sometimes is good, sometimes it's not. But the rest of the fingers is all affected, both sides.
Okay, I can see that you are pretty concerned with this. Hopefully by the end of this consultation, I can get to the bottom of this. So, Mr. Richard, you mentioned that all of your fingers are having experiencing this numbness, and
Mm,
it has been 3 months already. So,
mm.
how about your palms? Are they feeling the same numbness as well?
Yeah, sometimes I also have numbness over my palms.
All right. Can I have a look on your hand before as we continue?
Yeah, sure. This is my hand.
All right. Uh, before this, do you notice any changes over, or I mean, any painful over your hands as well?
Not really pain, it's more like numbness.
All right. Do you notice your ring has become more tight recently?
I don't wear ring, doctor.
Okay, sure, no problem. Other than that, how about your feet? Are they actually experiencing the same thing?
Sorry, sleep as in?
How about your feet, your legs?
Oh, my legs.
Yeah.
There's no numbness over my legs.
Okay. Did you notice that your legs actually become larger in time over the past 3 months?
Now you mention it, I realize that I need to change my shoe size from the size 8. Now it's almost size 10.
All right, sure. Other than that, may I know, are you experiencing any headache?
Headache? No,
Yeah.
no headache.
Okay. Any changes in your vision?
No.
Are you bumping into object recently?
Not that I know of.
Okay, sure. Other than that, do you notice that you're sweating easily?
Yeah, sometimes I realize that I do sweat a lot, although in aircon.
Okay, sure. Do you have any fever?
No.
How is your weight recently?
I think I gained a couple of weeks, but I didn't really measure, so I'm not sure.
Okay, sure. How is your appetite?
My appetite is good.
Okay. Any new skin changes which you notice?
I'm not sure, not too sure about that.
All right. Do you notice any lumps and bumps around your body?
No.
How is your sleep recently?
Sleep. I can sleep well, no problem.
Okay. May I know, are you married, Mr. Richard?
Um, I'm actually not married. I'm actually married, but I've got no children.
I see. All right. Did your partner actually complain that you're actually snoring while you're sleeping?
Yeah, sometimes she did tell me that I might snore.
Do you feel tired in the day?
You mean as in after waking up?
Yeah.
Yeah, sometimes I feel tired.
Do you easily doze off in the middle of doing something, like let's say watching TV or reading newspapers?
Yeah, sometimes if I read newspaper, I tend to doze off.
All right, sure. Um, Other than that, do you notice any changes in your bowel opening?
No,
Okay. Do you feel that you are passing motion more frequently?
no.
Any changes in your motions?
Has been same.
Okay. Any pain over your tummy?
No.
All right. Mr. Richard, I would like to ask a bit on your past history. Uh, were you under follow-up with other doctors for any illnesses?
Yeah, doctor. I have diabetes, doctor.
All right. How long has it been already?
Actually, I was diagnosed recently about 1 year ago, and then the
All right.
doctor told me my sugar control 3 months difference is about 7%.
All right. Did he actually adjust any of the medication?
Yeah, yeah. He started me on two medication, it's metformin, 2 tablets twice a day, linagliptin, 1 tablet per day.
Did he comment on the control of your sugar?
Yeah. He told me 7% can be improved
Okay.
further.
Okay. Did he recently increase the medication? So he increased the did he actually increase the dose of the medication that he prescribed to you?
1 year ago when I was diagnosed, I started off with 500 mg for the metformin, but then now it's already 1 gram. It was about 6 months ago.
I see. Uh, do you have any other medical condition which you'd like to inform me?
No,
Okay, sure. Um, were you taking any other medication other than your prescription?
no,
Okay. Are you having any allergy to medication?
no,
There are some, okay, I'm going to ask some questions that I've asked most of my patients. Hopefully you don't mind. Do you smoke, Mr. Richard?
no,
Do you consume alcohol by any chance?
no,
Okay. Are you taking any medication or any form of herbs for health
no,
or any traditional medications?
no,
Any medication for recreational use?
no.
All right. Um, recently, how about any medical condition that runs in your family?
Not that I'm aware.
Okay, sure. Recently, did you travel anywhere?
No.
All right. May I know what do you work as, Mr. Richard?
Yeah, I'm actually a professional pianist.
Okay. I believe this hand numbness has been actually disturbing your career.
Oh, actually, the numbness does not affect my career. In fact, I feel like my hands are quite easy to actually play the piano keys.
Sorry, could you repeat one more time?
Yeah. I realized that my hands are easier to actually travel between all the piano keys.
All right. Do you notice the hand become larger? Really?
Maybe there is a bit. I'm not really aware.
All right, sure. Mr. Richard, I'm going to have a look on you. At the same time, I'm going to ask some more questions. Will it be okay?
Yeah, sure.
Okay. I have a look on the patient's hand and notice that this is a spade-like hand, and also I proceed to examine for the median nerve, do a
Okay.
Tinel sign and a prayer sign to look for any numbness.
Okay. Tinel sign when you do about 10 seconds is actually positive. You feel numb over the both left wrist as well as the right wrist.
All right. So I proceed to the patient's face. Patient to look on the side to look for any jaw protrusion.
Okay. Side. There's no side photo, but yes, there is a bit of protrusion.
Okay, I have a look on the. I can see the patient nose a bit larger. Mr. Richard, any chance that you have your previous old photos or
Yeah,
your
I bring
IC?
my I bring my IC, but I did not bring it over to here, unfortunately.
All right, sure. I have a look on the tongue to look for macroglossia.
Okay.
Okay, I'm going to examine the visual field.
Mm-hmm. How are you going to
To
examine that?
I will use the call. I sit in front of the patient and then I ask the patient to close one eye and then I will check the visual field for each eye to look for harmonious hemianopia.
Okay. That is actually a bitemporal hemianopia.
Oh, okay. So subsequently, I proceed to the legs to appreciate the large legs.
Large legs. Yes, the legs is appear large compared to yours.
Okay, I will proceed to the abdomen examination to look for organomegaly.
Mm-hmm. When you lie down the patient, and as you go palpate the abdomen, there's no hepatosplenomegaly.
Okay, while examining, I'm looking for some skin tag, any skin tag as well.
Mm, Perhaps there's some over the left near the left auricular region.
Okay, I'm listening to the CDS to look for any murmur.
Okay, as you auscultate the lungs, as you auscultate the precordium, is S1, S2, there's no murmur.
All right, just to have a look on the patient hand again to feel for any sweatiness.
Patient appears sweaty in terms of the hand.
Okay, Mr. Richard, may I know, do you have any concern that you'd like to share with me?
Yeah, doctor. So actually, what am I having?
All right. Mr. Richard, I think you're having a condition called acromegaly. So sorry for this jargon. I'm going to explain it further. So, this condition is actually caused by the excessive hormone being secreted by the master gland inside your brain.
Mm-hmm.
So, to confirm this, I will need to do a detailed brain scan, which I'm going to arrange for you later. At the same time, I'm going to take some blood for you, and also I take some blood to check at the hormones and also the other hormones related to the master gland as well.
Wait. But
Uh,
what causes my hand numbness, doctor?
all right. So because of this condition, so you have also noticed that your hand are actually enlarging. So um, over over the hand, there's one nerve travel over your wrist. So because of the hand being larger, and it actually put on pressure to the nerve and causing this numbness also.
Okay. So you think it's due to some growth in my brain, is it?
I'm suspecting that at the moment.
Oh, but doctor, can my diabetes actually cause my hand numbness as well?
All right, there is a possibility for that as well. So, however, your diabetes
2 minutes left.
has only been diagnosed for a year, so it's less likely for the diabetes causing that. But to confirm this, we can run a test, which is an electrical current test over your hand, which can also confirm this diagnosis as well.
Oh, doctor, will I be able to continue playing the piano?
All right. We will have a look on the hand again. Also, we will refer to the hand surgeon to determine whether is it required for a surgery to be done. If the surgery has to be done, we will need you might need to be rested from your career for a while.
Okay. Do I need surgery?
This one I will refer to one of the hand doctors, and they can help you further and give you further advice on whether surgery needed to be done.
Yeah, but you told me I may have growth in my brain. I'm a bit worried. Do I need surgery for that?
Okay, for the brain surgery, it depends on the size of the growth as well, which we discuss further after the brain scan.
Oh, okay. Then do you think I have cancer?
At this point of time, it's not easy. Cancer is at the back of my mind, but we will need to get the imaging and also the hormone study from your blood done before we can come to this conclusion.
Okay, time's up. So yeah. So doctor, would you mind to tell me what is your full diagnosis and your differential diagnosis for this patient?
I think this patient is having a principal diagnosis of acromegaly, which brings up the complication of difficult to manage diabetes, uh, partly hypertension from the stem, and also obstructive sleep apnea as well. And also together with the patient principal complaint of carpal tunnel syndrome.
Okay, what is your differential diagnosis?
Different diagnosis will include diabetic nephropathy causing the hand numbness, as well as obesity. And also, I would like to work out for Cushing syndrome at the same
Mm-hmm.
time. Yeah.
Mm-hmm. Okay, any other differential?
Uh, I think that's all at the moment.
Okay, how will you investigate this patient?
Uh, Principally, this patient should undergone an MRI brain to look for any pituitary growth. Subsequently, I would like to refer the patient for a full set of hormonal profile, which basically starting with insulin-like growth factor 1 and a modified oral glucose tolerance test along with the growth hormone profile.
So
Subsequently,
what is the expected result for this patient? Let's say you carry
uh,
out this two.
when the patient take at the end of 2 hours, the insulin-like growth, I mean the growth hormone is not suppressed.
Mm-hmm. How about the
Yeah,
IGF-1?
the IGF-1 should be increased.
Okay. What are the other hormonal tests that you want to order?
I would also like to request for urine cortisol, serum cortisol. Subsequently, may need to consider a cytokine test as well. At the same time, I would also like to check for thyroid function test, as well as a 24-hour urine catecholamine.
Mhm.
Subsequently, besides the baseline bloods, I would
Sorry,
like to
what
request.
what is the reason of 24 hours urine catecholamine?
Sorry, I think there is more to urine cortisol. Sorry, the urine catecholamine is not related in this case.
Okay, all right. What are the
Yeah.
other tests?
The other test would be a vitamin B12 and folate level to as a part of workup for peripheral neuropathy.
Mm-hmm.
He, other than that, hemoglobin A1C. Previously, I would like to mention thyroid function test as well.
Mm-hmm.
Um, the other blood tests would need to be done would include full blood count to look for any macrocytic anemia, and subsequently a nerve conduction study for the median nerve specifically would need to be done as well.
Okay, what is the reason of looking at macrocytic anemia in this patient?
In B12 or B12 deficiency, it can be presented as a macrocytic anemia.
Mm-hmm. But do you ask about diet?
I think I missed on that.
Okay, never mind. So let's say this is the MRI pituitary gland actually shows enlargement. It's a macroprolactinemia. What is a macro pituitary lesion? So what is your management?
The management with the multidisciplinary approach involving an endocrinologist and neurosurgeon. Endocrinologist part would be the patient could be started on a carbagoline or bromocriptine, and at the same time we arrange for a transsphenoidal resection of the pituitary tumor.
Okay.
Subsequently, the patient will also need to be referred for occupation dietitian uh, for diet optimization, as well as a pre and early anesthesia assessment, as the patient might have a difficult intubation.
Anything else?
Post post of surgery, the patient need to be monitored closely in terms of electrolytes, as well as all the hormone replacement as well, including thyroid hormone and also steroid hormone.
Okay. So what are the other complication expected in this patient in terms of the disease itself?
This patient is experiencing obstructive sleep apnea, which I would like to further evaluate with a sleep study, and also an echocardiogram to look for any pulmonary hypertension.
Okay, I think that's all. Okay, so
Yeah,
I actually cut short your session because I have to minus about 1 or 2 minutes for the examination. Okay,
yeah.
but generally, okay, how would you feel in terms of your performance for this case?
I think because once I saw the hand, everything will point towards the acromegaly already, and then probably in between I missed some history that I need to ask. And in terms of examination, probably I need to do some pin prick also over the hands.
Okay, so again, the history, the presentation history is important. Even though the acromegaly, for example, is staring at you, you still need to go through the presenting complaint, the history, to ask about the numbness. Oh, you did not ask me what activity or anything that can make the numbness worse, anything that can improve it. You see, and then you did ask about any other parts of body that have numbness, but you didn't ask me whether there's any other weakness. Okay, so you see, you have to still go by the approach of hand numbness. You cannot straight away jump. Perhaps you can spend about 30 seconds to 1 minute for that, just to make sure that you are dealing with a carpal tunnel syndrome. Then only yes, you delve into acromegaly. This photo to you, I mean, if you don't look at the hand, right, you look at the face. Does the patient look acromegalic to you?
Actually, no.
Yeah. So you see, in real life, it's also the same. Not every time you will get a very classic acromegaly patient faces. The moment you saw the patient, you're like, okay, this one confirm acromegaly. Unfortunately, to be honest, I've seen a few. A lot of times, the acromegaly patient, they may not be very, very tall, very obvious, everything is enlarged. Some they are just like a bit obese and then almost like almost normal average height. So, and sometimes the facial feature is not very obvious. So sometimes may not be very obvious. So for this reason, because this is a virtual kind of practice, you will see the hand is like confirmed. You already compare with your own hand, right? You're sure that this is acromegaly. But in real exam, if you don't do side-to-side comparison, if you don't think of acromegaly, you may really miss the acromegaly with just a stem of hand numbness. And you may actually present this patient to have Cushing disease, for example, because if you ask further, there's no traditional medication usage, no steroid, less likely to be exogenous Cushing, can be more like a central cause. Okay, so you see, sometimes can be a bit tricky, but I feel like your approach to acromegaly is quite patchy. Don't you think so? Your history is a bit jumpy, and your examination is also quite jumpy.
Yeah.
So you for acromegaly, you must make sure that you will score well. I mean, all the points must be there. When the examiner asks you about full diagnosis, right? It is not, to me, it's better to mention the diagnosis based on the presentation first, which is the head numbness. I think the patient have bilateral carpal tunnel syndrome, most likely caused by acromegaly, and then complicated with, like what you say, obstructive sleep apnea, as well as visual disturbance, which is a bitemporal hemianopia. And let's say you examine further because you didn't examine proximal myopathy. So all this need to be mentioned as well, the full diagnosis, as well as the high blood pressure, new onset high blood pressure, and also difficult to control sugar, for example. So you need to mention everything together under complication. So don't rush in telling your diagnosis. You just go step one, step two, step three, like that. I mean, it's a like a ladder-based kind of diagnosis. At the same time, when you present your investigation also, you should go one by one. You shouldn't be very, enthusiastic and very anxious with it. The first test you mentioned is MRI pituitary gland. I know it's not wrong, but you see, you must know that what are the important things to actually mention in exam. Because in exam, you're not going to mention template answer like, okay, first I'll start with blood, IPC, full blood count to look for this, renal profile look for this, hormone panel look for this. So I would feel that if you present like that, a lot of time examiner may actually get bored, and it's very template kind of answer, and it's just like a buying time kind of approach when you are trying to squeeze in all the investigation that's important. But in my point of view is that if you encounter this patient, you want to show the examiner that you think this is acromegaly and you think the patient have bilateral carpal tunnel syndrome because of that. And therefore, when you structure your investigation, right, I will tell the examiner that, so firstly, to confirm the diagnosis of carpal tunnel syndrome, I will need to order some secondary blood tests to rule out some other causes. This will include vitamin B12, folate, thyroid function tests, as well as 24-hour urine cortisol to exclude Cushing. And definite tests will actually subject the patient for nerve conduction study or even the EMG, but it's mainly the NCS. Okay, so in terms of etiology, you can mention like that. I'm suspecting a pituitary macroadenoma. So for that reason, I will order a urgent hormonal panel, especially the anterior pituitary screening. This will include, for example, IGF-1 with risk. I'll proceed with 2 hours OGDT test. I'll expect non-suppressed growth hormone despite with oral glucose tolerance test. And following after, I also look at FSH, LH, TSH levels. I will also look at ACTH levels. And at the same time, I also look at the prolactin level as well. Sometimes can cause mass effect or stop effect to the posterior pituitary gland. And to confirm radiologically, I will do a MRI pituitary gland. Okay, to look for complication and association with acromegaly, I will order a sleep study to actually confirm diagnosis of obstructive sleep apnea. Or you don't want to mention that, you can also mention, like, for example, you want to stratify the patient with Edwards Spinner scale and then following after a sleep study. And then I will also do an echo cardiography, and I will also this will actually to rule out any concomitant heart failure or pulmonary hypertension. I will also order the scope for this patient as a surveillance screening because the risk of polyps is there, and also there's a risk of GI malignancy. And another thing is that I will also consider to another other complication you need to mention is actually, if let's say patient got any joint pain, you must ask the patient whether got any joint pain, hip pain or knee pain in particular, because a lot of time they can get this pseudo gout because of acromegaly. So if let's say there is, I will do a chest, we'll do an X-ray of the relevant joints to look for whether there's any degenerative changes. So all that should mention slowly. You see, your investigation should not be too jumpy. You should know that what you want to present. So the usual thing we want to order is like things that want to confirm the diagnosis of the chief complaint in particularly, and then you can split to biochemical, radiological, or electrophysiological, for example, and then you confirm with the underlying etiology. And this patient is not just enough to mention acromegaly. You must also give a differential diagnosis of possibility of MAN1 syndrome, multiple endocrine neoplasia. So for that, you may actually want to mention things like want to check for calcium level, want to check for PTH level, because I will expect, let's say the patient can have parathyroid hyperplasia, then the RPTH calcium will be high. And another thing to mention is actually, let's say patient have any altered bowel habit, like, but you did ask about that, but there's no. But let's say you have, so you may also want to look for things like gastrin or secretin, all these things. But it's not routinely mentioned. I would say it's not very important, but at least you must mention about the parathyroid part because it's one of the things that we routinely screen. So acromegaly not just good enough to mention about this primary pituitary microadenoma. There's also a component of parathyroid hyperplasia as well as pancreatic lesion. And you also want to mention, you also want to look for any stigmata, any cutaneous stigmata, because acromegaly is also associated with, for example, McCune-Albright syndrome. So you must also look for any skin hyperpigmentation. Okay. So actually, if you look at your mark sheet, I think you are okay in the sense of most of the thing you can get almost a full mark. But sometimes the examiner may not be happy in the sense of the flow of the flow of thought as well as the flow of presentation. So sometimes they may actually minus 1 or 2 marks in the com skill, but concern, I think you're okay. Identity physical sign, you need to be a bit more, I would say, more complete, because acromegaly is a very expected scenario, very common. And if you come out in exam just like thyroid, you need to make sure you are like everything must be there. Sometimes I would rather get a very complex case than acromegaly, a simple one, or even thyroid, because the expectation is quite high. Examiner may have this out a lot of checklists that if you must fulfill. For example, this patient will expect you to also examine the shoulder abduction and adduction to look for any proximal myopathy, okay, other than just checking for the wrist. And in this patient, when a patient have a carpal tunnel syndrome, you should also offer to check for the hand function, because actually the time is enough, okay. So this is just some of the things that mentioned. Yes, I mean the history I modified a bit, but yes, it's important that before you examine this patient, like let's say this patient I encountered in exam, I will tell the examiner before I even touch the patient, right? I will say that, sir, I noticed that the blood pressure of the patient is high in outside. I will write to request a repeat blood pressure, because you need to separate blood pressure reading to actually diagnose a hypertension. So it's also important for you to mention so the examiner aware that you notice that patient is hypertensive. Okay, examiner may or may not tell you the new blood pressure reading. It doesn't matter, but the idea is to let them know that you are aware the blood pressure is high, and only then you check for the hands, look for the features of the acromegaly. We'll go through in detail. Yes, you check for tinea sign, but not just enough for tinea sign. You must check for the power as well as sensation. You should do at least pinprick lah, I feel, and then you should try to delineate the margin of the medial fourth three, so-called 3 plus half of the sensory distribution loss. And you mentioned about the microgracia. You didn't mention about the tooth. There's an interdental space widening. And then important in this patient actually are calibrated as bitemporal hemianopia, because I think most of the time they will have bitemporal hemianopia unless they bring those stable acromegalic patient already post-operation, they got no residual defect of the vision, and then they change the scenario, then they may not have a bitemporal hemianopia. Okay, and then you also need to check the thyroid, because acromegaly is associated with thyroid disease as well. The goiter, you must also check. And at this point of time, when I check the neck, I will also ask the examiner telling that I want to measure the patient neck circumference. Okay, this will shows the examiner that you are thinking that okay, the patient may have an OSA. Okay, so yes, another differential I expect in carpal tunnel other than thyroid, diabetes, Cushing is actually the amyloidosis. Okay, because Acromegaly itself can also cause secondary amyloidosis. Okay, other than direct effect of causing the carpal tunnel syndrome. So I think the concern most of it you address all. So just rewind a bit when you encounter a scenario of hand numbness. Perhaps I give you too much clue from the first sentence when you ask me about hand numbness. I told you that my little finger seems okay, but the rest of it is normal. That's something is like a giveaway, but you still need to go by the usual approach. So when you prepare this scenario, Ben, when you prepare this scenario outside, what is your list of differential you wrote down?
Yeah, it's actually more to all the peripheral neuropathy
Mm-hmm.
causes. Yeah, the
Okay, other than
alcohol,
peripheral neuropathy,
I put
the,
all stroke also, stroke, drugs
mm,
and all like, yeah.
yeah. So, but how many checklists from this you miss based on your differential analysis outside?
You mean the checklist on,
This based on what I listed, which one you didn't mention? You didn't write down when you prepare.
actually, I don't quite understand your question, sorry, Jimmy.
The question is based on this list of differential diagnosis that I listed here,
All right.
which one of it that you didn't manage to write down when you prepare the scenario outside?
I think the hypocalcemia, Takayasu, and
Mm.
all the below, yeah. From after the rheumatoid or CTD, those below are all not there.
Mm. So you see, sometimes a scenario hand numbness, you must actually go through all this possibility. Okay. So when you encounter a carpal tunnel, you know that your job is not there. You must make sure the patient kidney is also okay. So in this patient, the moment you ask about diabetes 1 year diagnosis, you are happy that you didn't access the vision. You didn't ask whether the patient go for any eye checkup before and any faulty urine, any kidney check or any blood test done, doctor tell you got any kidney problem or not. It's also important because you can mention that if let's say patient got CKD, straight away diagnosis of DM already got CKD, and then you can also offer the part of the carpal tunnel secondary cause can be due to uh, long-standing chronic kidney disease. But this one is just 1 year of diabetes. Okay, but something that you can mention just lower down the list depending on the scenario. Raynaud disease and phenomenon is quite important as well. So that's why in your HOPI of hand numbness, like not enough to just ask about numbness per se. You also need you ask about pain, yes, but you didn't ask for weakness. And you didn't ask for any change in the color of your hand with the temperature. And then you didn't really screen through any systemic review of connective tissue disease. Hypocalcemia is something quite striking, and you may miss it if you don't think of it. Sometimes you won't notice that the let's say the fourth of the the fourth of the fifth metacarpal joint is actually shortened to suggest the, for example, the Albright hereditary AHO, Albright hereditary osteodystrophy or pseudohypoparathyroidism. It can happen, and sometimes you may also miss like leg bowing in the case of vitamin D deficiency. So hypercalcemia must always list down. Okay, Takayasu is like a favorite exam kind of scenario, which is not very common, but something that you want to mention. Let's say patient got, for example, got any history of cardiovascular risk, got high blood pressure, young hypertension particularly, and then also got some stroke. So you may want to mention, you may want to actually screen through leprosy, infective symptoms, skin lesion can kind of like exclude. Subclavian steel, thoracic outlet, you can also exclude easily based on history. What are the things that you can mention is that uh, you mentioned about the numbness. The numbness, anything you do can actually make the numbness worse. But let's say that as the surrogate told you that when they lift up their hands, they feel the numbness actually get worse, and then they also feel that some discomfort over the neck region. Then it tells you that this may be due to subclavian steel or some form of thoracic outlet obstruction. So, but if they didn't mention that, then it's fine. And then you may in this particular carpal tunnel, you want to know that usually carpal tunnel is mechanical pain, right? Sometimes they may have pain, sometimes they may have only numbness, and usually they may exacerbate with increased activity of the wrist fraction. So if they carry things, they hold object for long, they will feel numb. And then let's say they shake away their hand, it will tends to get better. Okay, so this is like a typical characteristic of carpal tunnel syndrome. Okay, so acromegaly, the reason I go through this scenario is because I feel it's important for us to go through this approach. When I encounter acromegaly case, after I go through the HOPI for hand numbness, I will straight away ask about this. Yes, most of it you ask, but some of it you actually did not ask. So you must go through. You can do something like what I do in my mental rehearsal. So I will try to confirm my diagnosis for history, any change in the face, hand size, finger size, or shoe size. You ask about the ring, which is good, but sometimes if patient didn't wear, then it's fine. And then at this moment of the face, you should straight away ask about old photograph or IC. And then skin changes, you must also ask whether any lumps over your neck or armpits. Okay. And then you must straight away ask about the complication. So in terms of this, I realized that because the thing that if you want to rule out, for example, parathyroid hyperplasia in association with MEN1, right, is the polyuria and some tummy pain that actually counts, or even the history of renal kidney stone, right? Polyuria is quite important for two reasons. It's because you can straight away screen for whether this is a parathyroid hyperplasia. At the same time, can this be due to uncontrolled diabetes? Okay, so you can also ask whether patient pass more urine, drink more water, and then the blood pressure control. This patient was not known to be high blood pressure, it's fine. And then carbohydrate you already asked, and then you also ask about brain vision, that's good. You also ask about OSA, very good. You screen for early morning headache and then sleepiness or snoring at night. You also but you did not ask about the neck swelling. It is important. No need to assess the thyroid status, but just ask a screening of any neck swelling. And then you must also ask about patient heart failure symptom. You did not ask about that. You must ask patient whether got any shortness of breath, in particular on long distance ambulation, or for example on lying flat with just one pillow, and then any sudden awakening at night, or any leg swelling. Okay. And then the pseudo gout is something I mentioned. Joint pain is something you need to ask. And then sometimes if depending on if you got time or not, if you want to appear more systematic, you can also ask about hypogonadism, in which do you have any sorry to ask this sensitive question, do you have any issue in your intimate relationship, any difficulty of morning erection, for example, if it's a man. And then you also want, yes, you ask about outer bowel habit, but you didn't ask any blood in the stool. So you see, I'm very OCD when it comes to acromegaly, because we really need to screen from the top to the bottom. And usually we screen for diabetes, hypertension, and then start from the hand, go to the eyes, okay, and then go to the neck, and then go to the heart, go to the joint, and probably I won't ask any tummy distension other than just a change in bowel habit. And then the next domain is actually you want to actually know the etiology, because you see, good that you ask about smoking, because we know that lung cancer can actually cause ectopic growth hormone production, in particularly some non-squamous cell kind of lung cancer. So it's actually important for you to screen for whether patient have any coughing or blood, any is he a smoker, if it's a heavy smoker. And then you also, yes, you ask about bumping things at the side when you walk, and then any double vision, which is good. You ask about that. But sometimes you will realize that the scenario usually will calibrate things like they don't realize they got this tunnel vision or narrow vision at the side. But when you examine the patient may have this bitemporal hemianopia. Okay. And then the last part is actually the association from the history. You ask about the loose stool, whether like, a patient have any change in bowel habit. Let's say there is any loose stool that is not improved with fasting. This will suggest secretory form of diarrhea. And then PTH part I already mentioned. And then the carni and also the macroalba is just basically some dark spot or skin pigmentation. Okay. So if you go through all this, your history, your acromegaly is complete. Okay. And then next is actually your examination. So it's not enough just to look at the hand, spit like doji, feel for the hand, feel the coarseness and the thickened skin and the sweatiness, and then only you perform a T-nail sign. I would also consider to ask the patient to offer to tell the examiner I will proceed with the Fallon sign. Usually because it takes time, the examiner will say skip. Even T-nail sign also, the examiner may say skip is positive, something like that, but you need to mention that. And then head, you also need to mention things like prominent supraorbital ridges, maxillary overgrowth, large enlarged nose, mouth or tongue, widened interdental separation. And this is just a feature when you look at the side, there's a pronectism in which the jaw is actually the jaw actually exceed the normal margin of the mandibles. Okay. And then you go to the eye. It's important. If you miss an eye visual field examination in acromegaly, you will fail the exam, because the examiner is very particular in this. You must always assess the vision. So it's important. So you did a very good job. You examine the visual field, and then it's not just enough for visual field, because of the mass effect. You need to make sure that the patient did not have some sort of optic atrophy. Okay, and also acromegaly can also cause cataract. So you must also offer only, no need to do, want to check for fundoscopy. Okay. And then you go to the neck and check for the neck swelling, like look for any skin tag. And also important to mention the acanthosis nigricans. After that, you go to the shoulder, right? So I will usually palpate, not the palpate, sorry, I will assess the power for proximal myopathy. And then after that, I go to the chest just to look for any axillary hair loss, any skin tag, again, any acanthosis nigricans. And the next thing is actually going to the cardiovascular. I will examine the attack speed and then listen to any murmurs. And then I will also lie down the patient if got time. If got no time, I will straight away just press the patient leg, especially the pedal edema, to look for any evidence of swelling. And then if you have GI disturbance, things like that, you may want to do a per-rectal examination to exclude any lower GI, any GI bleeding. And there's something that you can also offer. Sometimes I like to do this because I realize that a lot of candidates will not do. You can also request to check back the blood pressure, request the urine dip bedside, and also even do a ECG sometimes if it's indicated. And then other than that, you can also check the bedside sugar. Okay, so those that I underline is actually those things that suggest of active disease of acromegaly. So this actually includes sweaty palms, skin tags, pedal edema, which may suggest heart failure, and uncontrolled sugar, blood pressure, as well as glucosuria. So all these are actually a signs of active disease. Okay. So when you go to so-called acromegalic per se, right, after you finish with the carpal tunnel syndrome, another way to present all the endocrine disease is always you can do something like you want to offer a screening test, confirming test, localization, and also the association complication. So you go by screening, I will screen the patient with IGF-1. If it's elevated, confirm with OGDT. I will localize with MRI P2D scan and also PET-CT sometimes if you suspect whether there's any involvement elsewhere. And then we'll also want to look for any association complication. This will include HbA1c, UFAM, lipid profile, thyroid function, sleep study echo, pituitary hormone, colonoscopy. There's a lot of ways you want to present because when you only have 5 minutes to discuss with examiner, you want to keep things short as well. So you have to have your own kind of template, go through, and then when exam, you just mention it out without thinking much. Okay. All these are something you can be prepared instead of like waiting for the last minute, go to exam, encounter acromegaly, only you think of what you want to present. So all this is just to train your thought process. And then management, I'm not very satisfied with your management actually, because the first thing you mentioned is to start carbagoline in this patient. I feel the manager should always start with the magic word, which is the multidisciplinary approach, focusing on patient education, counseling, and this particular case also talk about non-pharmacological in terms of cardiovascular risk reduction, exercise, rate reduction, dietary modification, for example. And then pharmacologically want to do offer dopamine agonist like carbagoline and bromocriptine, somatostatin analog, octreotide, lanreotide. Prednisolone is something not available in Malaysia, but if most of the, especially the overseas examiner, will ask this kind of like a why kind of question because they want to know that whether you know that there's another agent other than just dopamine agonist or somatostatin analog, which is a GnRH antagonist, prednisolone. Okay, something important to mention. Surgical approach is transperineal surgery or a definitive one, but let's say if it fail or anything, second line will be radiotherapy and go back to medical therapy. Yeah, so basically that's it. So it's important for me to go through acromegaly so that everyone is well versed and everyone is prepared. Okay, so I think that's all. Do you have any question?
I think it's very clear. Thank you so much.
Okay, yeah. So I think you are almost there. It's just that you need to train your fluency and your flow of thoughts. Some certain examiner they don't like a very jumpy kind of history as well as the examination. It's same reason that for any other people that is going for exam, if you ask about the concern, you should not go take a ghost stand and then U-turn and ask back some history. Certain examiner don't like that. So after examining the patient, you can still ask some history, but the moment you want to ask about concern, you must sit down, look at the patient, and then just focusing asking about concern. You should not ask, go backtrack and ask about the remaining. I know in exam sometimes you're really desperate. It's not wrong to do that, but try to avoid doing that. You must show that you are confident and professional and following the thoughts. Your thoughts are clear and is systematic and structured. Okay. So with that, I think we can go to second candidate, which is Chris. Chris, are you there?
Yeah, I'm here.
Okay. So you are ready, yeah?
Yeah.
So I give you 4 minutes to prepare.
Sorry, may I ask is it a surrogate or is I'm taking history from Miss Fatima?
You are taking history from the daughter, as mentioned.
Okay.
Okay, time's up. Dr. Chris, this is the patient, daughter, Miss Aisha. You can
Good
start.
evening, Miss Aisha. I'm Dr. Tay. I'm a doctor in the neurology clinic. May I confirm, are you the daughter of Miss Fatima, 55 years old?
Yeah. My mom is actually on the bed, with the cot side up.
Okay. I understand that your mother come to our clinic for abnormal movement for 1 month. Can you tell me more about this?
Yeah, doctor. I noticed that my mom has been like having shivering all the time, like even when she sleep also like that. So we are very concerned. This abnormal movement is already been there for almost 1 month.
Is this the first time that your mother having this problem?
Yeah, one month before she never had this problem, but we start to realize this like 1 month. For the past 1 month, it actually persisted. Initially, we thought she's just having cold or any fever, but subsequently we realized that actually it's not, and then it's been going on in the morning until at night. And then it seems like she's tried to dance and then there's tendency to fall down. That's why we actually bring her up to the hospital today.
Okay. The shivering, is it the whole body shivering, or is it confined to particular body parts?
It is more like the whole body. The head is moving, the arms as well as the legs is all throwing around, moving here and there.
Is it getting worse?
I would say it's almost the same. There is no worsening in terms of the movement, like becoming more aggressive or not. She still can respond to us. It's just that she cannot stop the movement herself.
Is there any condition that relieve the shivering, relieve the movement?
Unfortunately, we try a few things. We go to Chinese Sensei, we go to some acupuncture. None of it actually works. No medication that also we try works as well. It's still persistent.
Can she still walk? Walk.
No. She cannot walk. She will fall down. That's why we don't allow her to do that.
Is there any body weakness?
No, she still can move her arms and leg.
Any body numbness?
She did not complain of that.
Any headache?
No,
Any visual problem?
no,
Any history of fitting before or seizure before?
no,
Any fever?
no,
Any history of frequent bumping into objects?
no,
Okay. Is there any chest pain, or is it chest pain?
no,
Breathlessness?
no.
How many pillow does she need to sleep?
She can sleep with one pillow.
Any leg swelling?
No,
Any cough?
no,
Okay. Any vomiting?
no,
Diarrhea?
no,
Any yellowish discoloration of the eye or skin?
no.
Okay. Tummy pain?
No.
May I ask how is your mother's bowel habit? Any change in her bowel habit?
Yeah. I mean, the bowel habit has been the same. She still can pass motion. There's no constipation or like diarrhea.
Okay. Any problem with urination?
No.
Okay. Any bubble in the urine?
She did not complain of that.
Blood in the urine?
No.
Okay. Is there any joint pain?
No.
Any body rash?
No.
Any lumps or bumps or swelling on the body?
No.
Okay. Any eye redness or eye pain?
No.
Any loss of hair?
No.
Any problem with like hand shakiness?
Hand shakiness. She has been having this shakiness all the time.
Okay. Any hand sweaty?
No.
How is the appetite?
She still can eat. It's just that we need a lot of supervision.
You mean supervision because you're worried about anything?
Yeah, because all the food will spill everywhere.
Oh, okay. Any recent weight change?
No.
Any history of fall for the past 1 month?
Not really, but there is a near episode of fall that we managed to prevent that.
Okay. May I ask, is there any medical condition that I should be aware of?
Yeah, so she actually have two conditions. She have diabetes, and she also have depression.
Okay. May I ask, diabetes, how long already?
Oh, almost 10 years already.
What medication is she taking for diabetes?
She's on only one type of medication, metformin, twice daily, with 2 tablets.
Okay. May I ask how is her diabetes control? The sugar
Yeah.
level?
So usually the 3 month kind of sugar checkup that she went recently last month was about 8%.
Okay. Any history of heart attack or stroke?
No.
Okay. Okay. For the depression, may I ask what medication is she taking?
Oh, she's on sertraline, 50 mg, one tablet per day, and also olanzapine, 5 mg, once daily.
Okay, 5 mg once daily. May I ask, is there any recent dose change?
No,
How long has she been taking these two medication?
you mean for depression?
Yeah,
Almost 1 years now.
1 year. Okay. No recent dose change, right?
No,
Does she take any other medication that she bought from elsewhere?
no.
Okay. Any history of surgery before?
No,
Apart from the medication, metformin, sertraline, and olanzapine, does she take any other medication?
no.
Okay. Is there any illnesses running in the family?
Like,
Is there any family member with a similar problem as your mother? Yeah, as your mother.
uh, not that I'm aware. I mean, I remember the my grandma used to have diabetes, but other than that, not really.
Okay. May I ask, uh, is Miss Fatima working? Working?
No. She's actually a housewife.
Okay. I'm gonna ask a little bit of a personal question. Um, may I ask, does Miss Fatima smoke?
No,
Uh, Sorry. The next question might be a little bit sensitive. But it might help me to get to the diagnosis. Does Miss Fatima ever take any alcohol before?
no,
Does Has she mentioned to you that perhaps she might have taken any drugs for recreational purpose?
no,
Okay, sorry for asking that.
no problem.
Okay. May I ask how is her period?
Her period was quite I mean was quite regular until 5 years ago she already stopped having period.
Okay, okay, okay. May I ask how many children does she have?
She have two children, me, myself, as well as my younger brother.
Okay, I would like to proceed to examine Miss Fatima. I want to examine look at her whole stature.
So when you look at the patient is lying on the bed. She is moving here and there. She's actually both of the cot bed is actually up, so the grill is up. So you look at her, she can greet you.
Okay. The GCS. I want to assess the GCS of the patient. Is it full?
Yeah, she can obey command.
Okay. I want to assess the upper limb. Is there any any tremor?
Yeah. So how do you assess for tremor?
I want to put her hand up straight. I mean straight and straight up.
As she try to put her hand straight up, seems like she cannot control it. The hand will the upper limb will actually move here and there as well.
Okay. Okay. Um. Okay. Is there any jaundice in the eye?
No.
No. Okay. I want to do a neurologic examination of the upper limb. Tone.
Tone is I mean there's a lot of voluntary movement, but roughly to you is quite normal.
Okay. What about the power?
Power is fine, it's 5, can resist.
Reflexes.
Reflexes is actually reflexes examiner say you can skip because she cannot really obey.
Okay. Any problem with the sensory sensation?
She
With
can
pinprick.
she can still feel your sensation.
Okay. Um, I want to do a cerebellar sign. Uh,
Mm-hmm.
I want to do a finger nose.
She cannot follow your command. You may
Okay.
skip this.
Okay. What about this other cokinesia?
She cannot do as well.
Okay. Any rigidity?
Okay. As you feel for the tone, you don't feel any rigidity.
Okay. Uh, okay. I go straight to the eye. I want to check for the any nystagmus.
No nystagmus.
Okay. Okay. Um. Okay. I want to do the quick screening of a cranial nerve examination. Is there any extraocular movement abnormality? Just do the H test.
She can obey. Her eyes can do the H test, no issue.
Okay. Can clench the teeth. And then any problem with the cranial nerve 5 can clench the teeth, and then
When
the
when you ask her to clench the teeth,
Hmm.
she keep up protruding her tongue. She cannot control that.
Okay. Any facial drooping?
No facial drooping.
Okay. Okay. Any problem with hearing?
No.
Okay. Any hoarseness of voice from the examination?
No.
Okay. When she protrude the tongue, any tongue deviation?
No.
Okay. I would like to do a,
2 minutes left.
okay. Miss Aisha, may I ask what is your concern?
Yeah, doctor. What my mom is having for all this abnormal movement?
Um, after my assessment, I'm suspecting your mother may have this abnormal movement due to the drug that she's taking, that drug that she's been taking for the past 1 year.
Oh, what is that, doctor?
Medication for her depression, sertraline and olanzapine, both have a risk that can cause her to have a body abnormal movement. But of course,
Okay.
I will need to do certain more tests to confirm my diagnosis. I will need to do a scan of your brain of your mom to make sure there's no abnormality in the brain.
Okay.
want
Will this condition gets worse?
If we able to diagnose, if we able to find out the exact cause and we treat it accordingly, it will not get worse.
Oh, then do you have any medication to control this, and is it curable?
We have medication that would help with controlling the abnormal movement. But we need to find the cause to treat it. Then only the symptom will resolve.
I see. So, doctor, is this abnormal movement is like a can this be some form of brain problem that can be passed down from generation to generation? Is it a family disease? Because I'm worried.
Okay, since there's no history of any disease running in your family, um, the possibility of family inheritance is seem to be unlikely, but I wouldn't rule that out completely.
Oh, okay. All right. Okay. So, okay, time's up. So, Dr. Chris, would you mind to go through your list of differential diagnosis and state your most likely diagnosis in this case?
Okay, my provisional diagnosis will be a drug-induced dyskinesia, likely secondary to sertraline and olanzapine.
What kind of dyskinesia is this behavior? I mean, what kind of abnormal movement based on your assessment?
And no movement at the upper limb and lower limb.
It's whole body, right? But then, I mean, what are the term for this abnormal movement?
Dystonia.
Dystonia.
No.
Okay. Never mind. So, what is your differential diagnosis?
But differential diagnosis will be number one, Parkinsonism and the cerebellar symptoms and cerebellar problem.
Okay. All right. So, how will you investigate this patient?
First of all, I would do a CT brain and CT brain and with contrast, as well as with or without MRI brain to look for any space occupying lesion in the brain. Number two, I would like to do an infective screening for infection, FPC, to look for leukocytosis, CRP to look for raised inflammatory markers. Number three, I will offer her if she's agreeable, I'll offer her a lumbar puncture and do send the cerebral spinal fluid for analysis to look for infection and also to look for autoimmune causes. For example, multiple sclerosis.
Okay, probably we'll rewind back a bit. So, what is the characteristic of this abnormal movement from history and your examination?
I did not really ask about the characteristic of the movement.
But the doctor told you it's a bit like dance
Yeah.
like, and then generalized, right?
Yeah,
Based on history. So based on this, what is the abnormal movement that you think the patient may have?
Balism. Hemivalism.
Hemi, but it's generalized.
I'm not sure.
Okay.
Mm.
Okay. What other? So is this abnormal movement? Is it like fast or slow?
This one I didn't ask. Yeah.
Let's say I tell you the abnormal movement is actually fast, but not very violent. So what is the type
Korea.
of movement? Okay. So if you think this is a chorea, so how will you investigate the patient?
Echo to look for any vegetation, particularly to look echo to look for any cardiomyopathy. I mean, I want to screen for rheumatic heart disease. So, want to look for I will auscultate the heart for any murmur, and then I will do a echo. I will send the inflammatory marker. I will expect it to be raised. He and wait yeah, and electrolyte to look for any electrolyte abnormality.
Okay, all right, never mind. How will you manage the patient?
Management of the patient will be multidisciplinary approach. This one I would definitely involve a neurology, and then if there's a cardiac involvement, I will involve a cardiology and also a physiotherapy team as well. And patient education and counseling. I will send the investigation that I mentioned, and treat the cause. The management will be depending on the cause. If there's a
Okay, so at this point of time, you don't know what's the cause is fine, but how do you any symptom control that you can give? Any medication?
I would offer benzodiazepine to relieve the abnormal movement.
Okay.
Yeah,
Any other element?
I'm not sure.
Okay, never mind. Time's up. Okay. Oh, very difficult scenario, right?
Yeah, it caught me off guard. Yeah.
Actually, it's difficult because I don't have any photo to show as well, but I can only describe with you. So I got this almost, I would say 90% similar case in the mock in Batu Pahat, which is also the same stem, a normal movement, and then the surrogate get the history, and then examine the patient. And to be honest, 5 minutes outside the scenario, I'm just ideal around. I don't know what else to do. I don't have much things that I write. So okay, my question to you is, because you have very difficulty to get the diagnosis right, what is the thing that you write outside?
My first thing is Huntington actually. Then there's a history. Then I like okay out already. Then the second thing is drug induced.
Then
the Parkinson and cerebella.
okay. Then where is your Huntington goes to the discussion? Totally disappeared.
Yeah, because I thought like no family history, then the age also like a bit too
But
old for
if
them.
you recall, the daughter said she's not sure, right? It's not to say no family history. She
Oh,
tell you she's not sure. So not sure, not equivalent to don't have, right? And
yeah.
what is the thing that will suggest this can be Huntington, other than the age?
Emotion, you know,
Emotion? Like what
uh,
emotion?
age, family, not sure. You mean functional decline?
Okay. So abnormal movement is one month, right? So patient got 1 year history of depression, right? So it's important for you to
Oh,
really ask how is the symptom,
yeah.
because usually Huntington is progressive. So despite with medication, no change in medication, right? The symptom usually will get worse. They will be a bit more moody. They will be very depressed. And in this patient, right, you should even ask for any risk of self-harm behavior.
Okay.
Very important, no? So when when you prepare a scenario outside, right? To be honest, when I prepare a scenario when I was in the same position with you, I actually write a few things and write, can this be Parkinsonism? If it's Parkinsonism, I will divide into primary, which is idiopathic, secondary Parkinsonism, or tertiary, so-called Parkinson plus lah. Then the second differential diagnosis, I actually put as the yes, I put as cerebellar, or so-called, I actually put chorea as number 2 before I go for cerebellar, and also some other thing like dystonia lah. So when I put chorea, so I actually straight away put as Huntington, I put as drug induced, I put as Sydenham chorea, which is the so-called rheumatic heart disease. I also put as some other rare causes like acanthocytosis, neuroacanthocytosis in particular. I also put as Wilson, put at copper, the copper disease, iron disease, can be thyroid function, can be some nutritional causes. And I also put for stroke, okay, because we know that stroke at the basal ganglia can also cause chorea. And not to forget, we know sometimes if you encounter enough patient in emergency, you encounter 1 or 2 rare chorea that is actually due to hyperglycemia. So uncontrolled DM is also one of the risk factor. They may have a chorea. Usually it's more like HHS type, not like a DKA kind of patient. So very hyperosmolality like that, and they tend to get chorea. So I will list down that, and then the rare one, like dystonia or cerebellar, I didn't really probe further because I want to know whether this is actually which one it belongs to. So abnormal behavior or abnormal movement in exam, right? When it come out, right, the commonest is still being Parkinson, and the second is actually chorea. Okay, dystonia is very rare. To be honest, I never see any scenario that actually came out dystonia. The reason is also being very unfair for patient, because difficult to control the patient in terms of dystonia, can be quite disabling. They cannot give history, most likely it's surrogate as well. And sometimes the dystonia can get very aggressive. Patient can fall down in exam, so may not be very safe to come for exam. But those chorea and Parkinson, they are very stable. So these are the one that they can actually come. And how to differentiate between these two is actually, other than examination, is to know their frequency. I mean, you don't ask about frequency, you actually ask, do you think the movement is fast or slow? Because you know that Parkinson is slow, right? But chorea is actually fast, okay? So that in movement disorder, we always want to classify the patient, can this be hypokinetic or hyperkinetic? Because this will give us to different diagnosis lah. So this one I won't go into the mark sheet because definitely you will not get a pass, because it's difficult scenario. It's a difficult scenario, but at least if you get like a drug-induced dyskinesia, maybe you can get like 1 or 2 marks in a critical judgment. But again, your differential diagnosis, actually the position diagnosis for this patient is Huntington chorea, Huntington chorea.
Okay.
What makes the drug-induced dyskinesia, also called tardive dyskinesia, less likely is because drug-induced dyskinesia usually will not cause such a florid or generalized chorea. They usually cause very focal chorea, like oral buccal dyskinesia. So usually they just move their mouth, cannot stop, and then the tongue keep on protruding out. Okay. So my question to you is, how do you know this is chorea based on examination? I mean, I didn't show you photo, I didn't show you video. This is a bit unfair, but you should know that you should know how to describe chorea. So how do you describe chorea?
Non-purposeful, non-reading movement of the limbs.
Okay, redoing dance like non-purposeful. Okay, and then is it stereotype or non-stereotype?
Non-stereotype.
Yeah, non-stereotype, right? It's not like tremor, not like dystonia. They only move in certain direction and back and forth like that. It's actually dance-like, wheelchair like, so it's non-stereotype. So you must mention all these keywords. So I think the patient have a working diagnosis of generalized chorea in view of non-purposeful, non-stereotypic, dance-like movement disorder. You should mention like that. You see? So if you mention like that, you can score. But examination is important for you to there's two signs that you must elicit before you tell the examiner that this is chorea. First is the ocular paresis. So if you ask the patient to look at you to fix the eye, when they fix at a certain, I mean, even at the resting gaze, the eyes will have reduced eye blinking. They will not able to look at you properly. And when you actually do a H test, they have difficulty to obey. But it's actually not like a ophthalmoplegia like that, cannot move at all. It's just that they have difficulty to fix the object. Okay, so this is what we call as ocular pharesis. Another thing is the motor impersistent that you need to elicit in exam. How do you elicit motor impersistent? Is you just ask the patient to hold your hand, grip your index or your third finger together using their hands. So what they do is actually they cannot grip your hand firmly. They will grip release. So this kind of grip release is what we call as motor impersistent. Cannot maintain the same motor movement. So it's what we call milk grip. Okay. Another thing that you accidentally explore just now when you try to examine the mouth is actually when you ask the patient to clench or to open the mouth, the tongue will actually keep on protrude out and in like that. They cannot control that. So this is again another motor impersistent. So with evidence of ocular paresis and motor impersistent, you can, and this dance-like non-stereotypic movement. So this is chorea. Okay, you must actually know that this is chorea. And one of the top differential diagnosis is actually Parkinsonism. So it's important for you to mention that there's no bradykinesia, there's no rigidity. Okay, and tremor is difficult because patient cannot obey. So it's important for you, for this patient, knowing that the patient have chorea, is to auscultate the heart. So the calibration will goes to auscultation of the heart. I remember I also auscultate the heart because I don't know what else to do. I'm like very, very blank. I even go and check for the Babinski to look for any stroke. So the calibration actually goes down to examine the heart for any murmur, which may suggest rheumatic heart disease. So in the history, if you're suspecting this is chorea already, you should already ask the patient got any childhood infection from the doctor, like whether patient get any childhood heart disease or childhood infection of the heart or the heart valve, things like that, to actually suggest that this be some for syndrome chorea. Okay. And
Okay.
you also want to check for the bedside sugar because hyperglycemia can cause chorea. Thyroid function, thyroid status in clinical, you just want to look for neck or any swelling or not, but it's not very important. Okay, so yes, the differential diagnosis can be is top differential because of, if you ask further, actually the depression symptom has been worsening for the past 1 year despite the same medication, although there's no suicidal ideation or like any self-harm behavior, and there's no evidence of stroke, no evidence of cognitive tissue or even thyroid symptom. So with that, your provision is Huntington, and then your differential is actually the drug-induced, you can say dyskinesia, but less likely because usually it involve oral buccal. Okay, and it can also be some other metabolic causes like hyperthyroid, hyperglycemia, or Wilson. Autoimmune, yes, you mentioned. SLE is a bit too late of her age, but you screen through the autoimmune symptoms, then you shouldn't have any positive to suggest that. Sometimes those hematological disease, particularly polycythemia, or even some paraneoplastic causes can actually cause chorea, but they are not common. They are what we call myeloproliferative disorder. Very rare, they can cause that. And there's some Huntington and Huntington-like syndrome, which is for example, PECAN. PECAN is like a neurotrainee kind of level, but it just basically means iron deposition in the basal ganglia. Okay, if you look at MRI, you will see it's a face of the tiger kind of sign. And then NA is actually neural accumulation of iron disease. It's an auto-inflammation of the brain because of the iron deposition. So differential diagnosis, Huntington disease or Huntington-like or Parkinsonism, autoimmune disease, metabolic causes. And because if you already list out all these differentials, so then your investigation becomes easy. You want to look for PBF, you want to look for neuroacanthocytosis, polycythemia, you want to check the sugar control because patient is also diabetic, and then you want to look for copper screening, autoimmune screening, brain imaging, or even consider genetic study for diagnostic purpose, especially in the case of Huntington. Okay, so let's say you don't know this Huntington, you know this is Korea lah. Your mention is not differ much because you can always mention education is multidisciplinary team approach, education counseling, caregiver training. We could refer to the OT, PT, speech, dietitian, support group, neurological referral, genetic counselor if suspecting on genetical causes, and then you can actually start some low dose antipsychotic. Actually, usually for Korea, we don't use benzo because benzo they tend to be very sedative. Usually we use very very low dose of halo. We are talking about like 2.5 mg or even 1 or 2 mg like that. Those like regular QID or TDS like that. So usually we give a low dose haloperidol to suppress the chorea. Okay, so concerned but definitely you cannot get a mark because one of the concerned family disease. The concern is not valid because you're not thinking that this is Huntington. Okay, so just want to go through movement disorder, right? When I talk about hypokinetic, so like what I mentioned to you, if you prepare a scenario at normal movement, you don't know what is the thing that's abnormal. Probably you should go. It's always safe to put the patient. Can this be Parkinson? Can be idiopathic, can be secondary, can be Parkinson plus. If it's a hyperkinetic, you have to rule out chorea. Okay. The rest of it, like myoclonus dystonia, is very rare. I never encountered any, and from the history, from the record, never come out before. Okay, so it's less likely. Okay, tics, I don't know, but never see before as well. But Wilson, very rare also because very difficult to find a patient with Wilson in Malaysia. In overseas, possible. So you see all this kind of condition. Mainly, you just narrow a differential to Parkinsonism, chorea, and others. Okay, so how to differentiate between tardive dyskinesia and Huntington, right? TD is tardive dyskinesia. So you can see that actually usually tardive dyskinesia is more like stereotypy instead of non-stereotypy in Huntington because they usually just like tongue protrusion, just like milkmaid grip, just like ocular paresis. They are very stereotyped, and then they have lip smacking. They have you can see tongue movement at rest, voluntary suppression of the buccal. They try to suppress, but it's difficult. Okay, Huntington definitely you cannot do anything lah. Okay, speech and language usually not affected in tardive dyskinesia. Huntington usually they will have some reduced speech. Okay, but depending on the stage, movement pattern usually both also can involve generalized, but usually tardive tends to be a bit more focal or sometimes be truncal as well. And then you can see that generalized is more to Huntington. Semi-purposeful usually is not purposeful, and then balance and gait usually will affect by movement. That's why most of the time they cannot walk. Okay, tardive usually they can walk, and then motor and persistence is another strong clue with some ocular paresis. You can see that these two are the very strong clue, and then the rest of it like spasticity, frontal lobe is difficult to elicit. But just to get an idea of how to differentiate between these two, because tardive dyskinesia is definitely one of your differential diagnoses, and you want to choose between tardive dyskinesia and Huntington, you need to justify yourself. Okay, so chorea, this is how I approach for chorea, and also based on my consultant in the past. So you can stage the chorea according to the timing itself or the pattern of involvement. So you stage by the timing, whether it's acute, subacute, or chronic. So if it's like a 1 day or 2 day history, or even like less than 1 week, it's more like acute. So you want to rule out those metabolic, muscular, or even drugs first. Subacute usually like metabolic as well, and also autoimmune. Patient who is pregnant also must offer a differential diagnosis of chorea gravidarum. Pregnancy can also cause chorea, but not common. And then chronic one, like this patient, almost 1 month already. So definitely you want to look out like Huntington disease or neuroacanthocytosis or like polycythemia as one of the more high likely differential compared to others. So depending on symmetry, if it's a focal, then usually like hemichorea, then you're thinking more to space accommodation, can be stroke, can be abscess, anything that affect the basal ganglia. Can be metabolic. Hyperglycemia, commonly they present with hemichorea, but sometimes when the sugar very high, storm, so they will go into generalized chorea as well. Autoimmune pregnancy again can be generalized or bilateral. Usually you want to go Huntington first or Huntington-like syndrome. And then drugs is the medication, for example, neuroleptics or even Parkinson. Common scenario if the patient have chorea, tardive dyskinesia, ask the past medical history, patient actually got Parkinson. So you know that most likely is because of the MADOPA or the levodopa. So most likely is because of the levodopa induced dyskinesia. It can happen, okay? So this is also important to put in your differential diagnosis, which I didn't mention because patient don't have Parkinson. Okay, other than that, the systemic causes like autoimmune, metabolic, hematological, or pregnancy is all just the same approach. Okay, so generally not much of differential diagnosis of chorea. But again, this approach will help you to localize which types and then get your differential. Okay, all right. Chris, any other question?
No more question already. Thank you.
Okay, thanks. I think everyone, if anyone have any question, can just type on the chat. So next we'll proceed with Brian. Brian, are you there?
Yes.
Yeah, Brian, you are
Yeah.
ready, right?
Yeah. Ready?
So I give you 4 minutes. Time start now. All right, 4 minutes up.
Okay.
So this is the patient, Madam Wali. You can start.
Okay. Hi, good evening, Madam Wali. Can I confirm that you are 38 years old and I'm the doctor here today?
Yeah, I'm Wali.
Okay. Okay, I understand that you have been having headache for past 7 days. Can you tell me more about that?
Yeah, doctor, I'm been having headache for almost 1 week. It actually started off gradually, but subsequently it become very throbbing in nature. I feel like uh it's very disturbing to me.
All right, I understand. I understand that must be very difficult for you. Can you tell me where is the headache? Is it left side, both side, or specifically on one side?
So it actually more on the right side, over my this right upper side of the head.
Okay, is it first episode? Last time you don't have any headache, this kind of headache before?
Actually, I have a long-standing headache in the past. I used to have a headache when I feel stressed at work and has been there intermittently for almost 6 months. But this
All right.
headache, but this headache is quite different because it actually at the right side only.
Okay, so it's different from that. Would you mind rate your headache? How pain is it? Zero, no pain. 10 is the pain the worst pain you are having. Mm,
So when I have this headache,
mm,
actually about 7 to 8 out of
seven
10.
to, okay, usually how long does it last?
It usually lasts actually quite persistent, but can be intermittent. It usually lasts like 2 or 3 hours like that.
Okay, how many times per day?
So it has been almost every time other than when I take some medication, it will feels a bit better. So I would
Okay,
say that probably about 8 to 10 times per day.
all right, okay. So does the headache radiate to anywhere else
No, it usually stays just at the right side of
at the
the head.
at the right side lah? Okay, all right. Is there anything that make the headache worse or anything that make the headache better?
If I take some painkillers like paracetamol, it tends
Mm,
to get a bit better.
okay, all right. Anything make it worse?
Not really.
Not really. Okay. Any other symptoms like vomiting, early morning vomiting?
No,
No. Any blurry vision? Any problem with your vision?
no.
No. Can I ask when's your last menstrual period?
My last menses was about 2 weeks ago. It was
2 weeks
quite
ago.
regular in the past.
Okay. Do you have any when you have this headache, do you have any clear fluids coming out from your eye or your nose? You are having sneezing like that?
No,
No. Okay. When you are having this kind of headache, are you afraid of looking at light and also afraid of sound?
no.
No. Okay. Um, any numbness over the face?
Numbness over my face. No,
Yeah. Any pain over your face?
no,
Okay. Any redness over your eye?
no,
No. Okay. Um, any fever, cough, runny nose?
no.
No. Any weakness or fitting or any change in your voice or any change in your speech?
Sorry. One by one.
Oh,
You
sorry.
sorry.
Okay.
What you mentioned?
Any weakness?
No weakness.
Any change in your voice or your speech?
It has been same.
And so, okay. Loss of weight, loss of appetite.
I think my appetite is just the same.
That's the same. Loss of weight. No, no loss of weight.
No,
Okay. Um, hmm. Any chest pain, any shortness of breath,
no,
any change in bowel habit.
no,
Okay. Any pain over your calf.
no,
Any problem with urination or your walk or your the way you walk.
no.
Okay. All right. So previously, do you have any medical condition other than your regular headache?
Yeah, like I mentioned, I do have intermittent headache when I feel stressed at work lah. Other than that, I don't have anything of note.
Okay. Are you on regular follow-up for the headache?
No, I usually just visit GP when I feel unwell.
Okay. Um, all right. What medication are you on currently?
I only take paracetamol if I needed it, like up to maximum of one day 4 times.
Okay. Any over-the-counter medication that you take regularly for the headache?
Other than the paracetamol, no.
Okay. Any traditional medication you have been taking for this problem?
No.
Okay. This is a question I ask everyone. Would you mind tell me if you have any high risk behavior before, any unsafe sex, or any um using of recreational drugs?
No.
No. Okay. Any past surgical history?
No.
Okay. Do you smoke? Do you smoke?
No.
Do you drink any alcohol?
No.
Okay. Is there any family history of running illnesses in your family, like any sudden death or any brain cancer in your family?
No.
No. Okay. What do you work as?
I actually work as typist.
Typist. Okay. How is your work regularly? If you
Yeah, recently
in
also a lot of stress, got multiple assignment, but this headache is different and it actually disturb my work. I cannot feel, cannot focus.
okay, all right. I understand this headache is disturbing you. We'll get to the bottom of this problem. Hope the consultation will help you. Other than this, do you have any change in your diet or any change in your recent uh, sleeping pattern?
No.
No. Okay. Um, all right. I would like to proceed to examination.
Okay.
Okay. From the uh, peripheral, is there any sign of tremors or any pallor,
No.
any nail changes or any uh, skin changes like redness or any raw spot?
No.
Okay. Uh, all right. Looking at the face, I will check the conjunctiva and also whether there's any sclera jaundice.
No. No jaundice.
Jaundice, okay. Is there any redness over the eye, any eye discharge?
No eye discharge.
Okay. Any facial asymmetry or any nystagmus?
No nystagmus or facial asymmetry.
Okay, I will perform a cranial nerve examination as well, a quick one, just to look at whether there's any ophthalmoplegia, any change in visual field.
So when you examine for the vision, so she can do a H test very well. She can, there's no ophthalmoplegia.
Mm.
And then when you do a visual confrontation, there is also no visual field defect.
Visual field defect. All right. Any trigeminal nerve neuropathy, like any cranial nerve fifth numbness?
No.
Any change pain? No pain during eye movement, right?
No.
Okay. So we'll perform. I'll check whether there's any neck swelling.
No.
Or okay, any Brzezinski sign or any Koenig sign.
No.
No. Okay. Listen to the heart. Whether there's any murmurs or any crepitation.
No. Just now you mentioned neck swelling, right?
Mm-mm. Yes.
Not neck stiffness, right?
I mentioned neck swelling and also Koenig sign and also the Brzezinski sign.
Correct. No.
No. Okay. Would like to proceed with abdomen. Any organomegaly or any rashes?
No.
Okay. Any I will proceed with neurological examination, power of the upper limb.
No. Power upper limb is
Mm,
normal. It's
okay.
normal. Normal as well.
Okay, the reflex and tone.
Reflex is normal. Present.
Okay, the tone is normal.
Yep.
Okay. Sensation.
Sensation is also intact.
Okay. How about the lower limb? Power.
Lower limb power is the same.
Okay.
Sensation is there. Power is full. Tone is
Ref-
normal.
Reflex.
Reflex is also present. Panta is
Okay.
downgoing.
All right. I'd like to check for cerebellar sign and also ask the patient to walk to check for the gait.
So you ask the patient to walk. Patient can walk without any difficulty.
Okay. All right. Any lower limb swelling?
No swelling.
Okay, all right. I've completed my examination. Just would like to ask Madam Vali, do you have any concern that you might want to tell me?
2 minutes left. So yeah, doctor, what do I have, doctor?
Okay, so based on my history taking from you, um, you might be having a migraine, which is a headache that usually is one side, requiring make you to have requiring certain medication to help with the pain, and then your history that you have given me is points to that, and then upon checking your neurology, your function all is normal. So um, we will proceed with further blood tests and also imaging to make sure there's no any other sinister cause of the headache. And then any other concern you would like me to know?
Yeah, doctor, do I need admission?
So far, based on my assessment, it can be an outpatient consultation. No need for admission yet, but we will arrange for imaging for outpatient and then also give you some painkillers to manage your pain, and then send some blood tests to make sure every blood test is normal.
Okay, do I need any medication lifelong?
Lifelong medication, we will start trial of some medication that help you on the headache, and then after that we will follow up, and then we assess your pain, and then we will adjust the medication from that.
Okay, and is this condition treatable?
Yeah, this condition is treatable, and then is controllable as well if we have established the diagnosis, and then if the compliance is there, and then no other dangerous causes, then it is controllable and treatable.
Yeah, doctor, any issue if I want to plan for my pregnancy?
Yeah, so pregnancy wise, if you are planning for pregnancy, we will definitely review a medication we want to start to make sure there's no any medication that is not uh, that is bad for your baby. Yeah.
Okay, right.
Cool.
Time's up. So, okay, so can you go through a list of your differential diagnosis and mention your provisional diagnosis?
Okay, so my provisional diagnosis would be migraine.
Mm-hmm.
List of differential diagnosis, tensional headache, and then medication overuse headache, um, cluster headache, and also cerebral venous thrombosis. Yeah, that's it.
So among all your differential diagnosis, what are the things that may actually suggest which one is more likely than the other?
Um, Among list of my differential diagnoses, I would uh, proceed with migraine because the headache is unilateral, and then neurological examination is normal, and no other associated sign of other differential like cluster headache, and then trigeminal neuralgia, and then also cerebral venous thrombosis.
Okay, but the patient told you the headache is a bit different than his her usual headache, right?
Yes, the headache is a bit different. Yeah, correct.
Okay, all right. So, okay, how will you investigate further regarding this patient?
Okay, to establish the diagnosis, I will um, proceed with blood test to FVC to make sure there's any inflammatory marker raised, electrolytes, no any abnormality in the electrolyte, and then ECG, and then also um, imaging. We'll proceed with plain CT brain to rule out any space occupying lesion, and then also intracerebral bleed.
Okay.
Okay.
Any other tests?
Any other test would be liver function test to have a baseline blood for in order to start the medication, and then renal profile, coagulation studies to make sure to make sure no coagulopathy.
Mm-hmm. Okay, how will you manage this patient?
Yeah, regarding management of this patient, I will involve multidisciplinary team. Will start. I will refer patient to a neurologist for follow up of the primary problem, and then refer occupational health to help regarding the headache and her work. And if there's any psychology service needed, I would like to proceed with that as well for her stresses. And then medication wise, I will start the patient on
Start on what?
start on migraine medication such as triptans
Mm-hmm.
for the headache, and then also explain the diagnosis to the patient, and then patient counseling, and also migraine diary, and then also advice for lifestyle changes.
Okay, all
Yeah.
right. I think time's up.
Yeah.
So let's stop here.
Yeah.
Yeah. So Brian,
Yeah.
what do you think about your performance?
I actually the primary diagnosis I'm not very sure.
So when you encounter a scenario like that, you know that something is wrong, something is fishy.
Yeah.
And when your history can complete like 6 minutes, then you go and examine the patient, also mean that maybe your history is not enough. Oh?
Yeah.
So my comment to you is actually your history taking, right? Are you going for exam soon?
No. This my I'm just practicing for the first time only.
I see. Sure. Yeah, I do think that you need more time and also more practice because actually your history presenting complaint is not complete. Your headache history based on what you gather cannot tell you which type of headache is that. Okay. Another thing is that your headache, the patient told you is different from her usual headache. And you know what is the diagnostic criteria for migraine headache?
Migraine headache unilateral and usually lasts 3 to 4 hours per day, associated with photophobia, phonophobia.
The prodrome usually 1 hour
Yeah.
before the symptom, right?
Yeah.
But then, do you think the patient fulfill the diagnosis of migraine?
No, the frequency is too much. I think that not
Too
fulfilling.
long, right? I mean,
Too
the
long.
frequency is too long and persistent.
Yeah.
Yeah. And usually migraine will have a precipitant factor, for example, like coffee, for example, something sweet. So usually they may have a bit of precipitant factor, and usually they will feel that they have some prodrome symptom, like for example, tummy discomfort, blurring of vision, like what you say lah, all the 1 hours before the headache. And usually it occurs almost every month, and then at least to justify the chronic is actually, sorry, there's echo at the back. So to justify the chronic part actually must last for at least 3 months, and then each course there's a more specific criteria that I cannot recall, but actually the history does not look like migraine lah. So the thing is that, do you think the headache is something warning, because she told you that the headache is different than the usual headache, like not like a tension, like a stress kind of headache, right? So you need to, yeah, can you remove the echo, or like probably you can just turn off your mic for a while? Okay, all right.
Okay.
So the thing is that your headache history is not complete. Your Socrates is not complete. You mentioned about site, onset, yes. Characteristic, yes. I told you it's actually throbbing, and then in terms of relieving factor, exacerbating factor, you asked about that. Yeah, you also asked about the pain score, which is good, but you did not ask enough associated symptom. So if you ask me further, I will tell you that the patient actually have jerky movement a few weeks ago, 2 weeks ago. So you see your neurological associated symptom is not enough. Not just enough to ask about vision, weakness, numbness. You also need to ask about seizure. Okay, because tissue is very important thing in headache. Another thing you need to exclude, like really gao exclude, is the infective symptom, which you did. I mean, you also, but you didn't really ask about neck stiffness. You asked mainly about the photophobia, which is okay. Another thing is the pituitary symptom. In a approach, remember everyone, if you encounter a scenario of acute headache in patient's exam, your your differential diagnosis and your screening must always screen for pituitary symptom. What you mean by pituitary symptom is other than double vision, you must ask about any bumping of things at the side as you walk. This will suggest what we call as macroadenoma, in which it compress on the optic chiasm, but this is just compressive, not the hormonal. But so you need to ask about all the hormonal symptoms, which may include what? Which include, do you have any change in your do you notice any increase in your shoe size, any wing size? Do you have any change in your facial features? This is suggest acromegaly. Next is actually, do you have any weakness over your body? Do you have any skin darkening? Usually Cushing disease don't have skin darkening. Do you have any dizziness as you change position? But they will have a bit of this postural dizziness, as well as the Cushing knot feature lah. Do you have any with excessive weight gain? You did ask about the weight change, okay? But you need to ask specific. Another thing is that what can this be as well? You have to ask about the hypopituitarism. So I must ask about the thyroid status. Do you have any weather preference? But you don't want to ask weather preference. You can ask about, do you have any are you unable to tolerate hot or cold weather? Do you have any hand shakiness? Do you have any change in terms of your menses, change in terms of your bowel habit, change in terms of your easy sweating or any hair loss? So you must ask about that. And then next thing is actually the hypopituitarism, which involve the sexual dysfunction. So you need to ask about, do you have any reduce in terms of your sexual function? You can ask directly after you give like ask the sensitive question, kind of like a alarm question before you ask, or you can ask about, do you have any issues in your intimate relationship as well? You can just ask a simple, very indirect question like that, just to screen. So you must really screen for the pituitary symptom, because we know that acute headache, while your differential diagnosis, you must always exclude is pituitary apoplexy with the underlying diagnosis of some form of pituitary adenoma. So this is one of the diagnoses that you must always exclude. And in terms of the HOPI for the headache severity, right, patient mentioned to you is a 7 to 8. Okay, regardless what scale that the patient mentioned to you, you should ask the patient, is this the worst headache ever in your life? Because that may suggest this can be subaneroid hemorrhage as well. And with the subaneroid hemorrhage, you may want to think about things like, for example, polycystic kidney disease that predispose the patient to have SAH. Patient can also have, for example, what I want to mention is the HHT, hereditary hemorrhagic telangiectasia. Those patients can also have some form of SAH, or those patients with some form of young uncontrolled hypertension can also be predisposed to all this. So you must actually try to exclude. You can now see that your HOPI is very important to give you a clue which direction. So this one is like only one side, right side of the headache, and it persists there, and then it has been lasted for almost 1 week, never resolved. So the next thing is actually you must put your differential to high enough, which is a CVT, cerebral venous thrombosis. So cerebral venous thrombosis can be infective or non-infective. Infective can be because of some ENT infection, like otitis media, for example, ear discharge. You can ask about that. Any fever, any flu symptom, any ear discharge. This is a screen for infective. Non-infective one, always remember, look at the patient age back. Patient is 38 years old. So if patient has thrombosis, this is a young thrombosis. So you need to tell yourself that if this is a young thrombosis, you need to rule out all the hyperviscosity syndrome, all the thrombophilic screening. So again, you need to rule out, for example, IBD, you need to rule out nephrotic syndrome, you need to rule out PNH, especially in male, female less likely. You need to rule out APLS, very important. Because if you don't think about that, that's why you will not ask routinely, okay? And you need to know what is the precipitating factor. So things like, for example, travel history is important, whether patient got any long haul flight or immobilization history, surgery, you ask about that. You need to ask whether patient is taking any hormone pills, it's important, okay? So you need to know all this. And then you also need to screen for connective tissue disease. So you must screen for joint pain, rash, skin any rash precipitated by hot weather or any under hot sun, or any skin tightening, any joint pain, any neck pain, or even hip pain. So all that will actually help you to screen a bit on the connective tissue disease. You're not doing a full CTD screening, because a full CTD I won't go through today. You can refer to my notes later on if you have. And then but the thing is that you need to make sure everything is excluded. And one of the things, if you're thinking of cerebral venous thrombosis, is to ask for vaccine history, something that is a bit special that you won't routinely ask unless a certain scenario. Because we know that VITT is a known entity, especially, I mean, not to mention which brand of the vaccine that is that, but we know that vaccine actually carry a risk to induce vaccine-induced thrombocytopenic thrombotic thrombocytopenia, which is the one of the form of so-called synonymous to the heparin-induced thrombocytopenia. So we know that vaccine is also one of the risks. That's why you need to ask. Okay, and when you go to gynae history, female always ask about 4 key: period, pregnancy, pill, and also past pregnancy complication. So you need to really ask whether patient have any when patient start to achieve menarche, start to have period, and is the period regular or not, and whether patient is pregnant or not. Because you didn't ask about anything about obstetric history. If you ask, I will tell you that patient got 1 son, but she had 2 miscarriages. These 2 miscarriages, if you get the history, you know that okay, maybe this is APRS, because it's already got a red flag there. Another thing is that you also need to ask any complication after delivery, and then whether patient is on any hormonal pills. If you ask patient actually use OCP for family control purpose, so it's again very important. If you get all this information, you will know that this is more likely is a CVT and then precipitated by the OCP use, probably underlying cause of APLS. APLS can be primary APLS, can be secondary APLS because of connective tissue disease or hematological disease. So you see, it's important for you to really go in detail in the history. When you can finish history in 6 minutes, it means to say you really miss out something. And most often, sometimes the history is quite crucial. If you miss out all these important points, you will not get the diagnosis. Okay, so it's also important if patient with acute headache, other than examine the vitals, you must also examine the neck, feel for neck stiffness. You don't really have to do Buzinski or Koenig sign at all, but you must just feel for any neck stiffness, because in subaneuric bleed or even in meningitis, they usually will have neck stiffness. Okay, one of the clue is that. And at the same time, you want to rule out any pituitary kind of screening, any phases, any feature or stigmata. For example, skin bruising or Cushingoid feature will suggest to you is this a Cushing disease, can be pituitary adenoma. For example, there's an acromegaly feature in which we discussed just now. It can also mean pituitary causes. Okay, neuro, the important part is really to examine the second nerve, third nerve, which 4 and 6, 3, 4, and 6 is together. You want to examine trigeminal is also important as well, because can be trigeminal neuralgia. So probably somewhere between 2 to 6 is what you must examine. Depending on whether patient got hearing loss or not, if you got time, you can just screen whether patient got any hearing loss. Okay, and then ask patient can swallow or not. Don't have to offer to do a gag reflex. You want to check for tongue deviation is also fine, but generally you need to know what is you are looking for. You are actually looking for any hemianopia pantemporal to suggest hypopituitarism. You are examining for any third nerve, isolated third nerve or combined third nerve to suggest surgical tunnel palsy in the case of, for example, SAH with so-called rupture of the berry aneurysm. Okay, so this is also all important. And then your fundoscopy is also important. You must mention anyone with headache, and after checking the vision, it's an automatic response that you must mention that I want to offer to check the fundoscopy to look for this papillodema. Okay, so in exam you don't have full time to examine the full upper limb or lower limb. So upper limb usually I will just do a quick screening with pronator drift first. No pronator drift, then I just roughly go through the tone, power, reflex and sensation. If I don't have time for lower limb, I will just check for plantar reflex. But if I have time, I will just at least ask patient to walk and look for the gait. Okay, because this is a long case. In the past, when this is just 10 minutes thing, imagine it's the same scenario, same finding, but you just got like 8 minutes to attend to the patient, including history. So in those days, we don't have time. We just pronatative and Bantam reflex. That's what our tutor used to teach us. But in the long case like this, you need to examine the upper limb at least, and then you want to check for Bantam effect, is fine. Okay. So if you get all this information, you can give a differential that this can be most likely is CVT. It can be due to CNS infection, vasculitis, drug-induced headache, can be due to flare or migraine, tension headache, can be also due to VITT, let's say it's vaccine related. Because you cannot exclude the possibility patient have COVID vaccine 6 months ago, if you ask. Another special entity of headache in patient scenario is patient with family with active relationship, with intimate relationship. You want to ask when what activity or anything that can make the headache worse. So one of the things that you must exclude is the postcoital headache. It's one of the kind of like MRCP kind of like favorite question, because they tend to, if screen the primary headache, it's not likely, and then everything seems negative, examination also negative. But the only way you can get analysis is if you ask the history, actually any issue in your intimate relationship, then the patient will tell you that, oh, actually after the intimate relationship I feel this headache, then you know your diagnosis. Okay, so sometimes all these are not very straightforward. So investigation is directed to your differential, because you don't have differential, that's why you cannot give a good investigation. Football count particularly want to do for polycythemia, because we know that MPM, minor peripheral disorder, can actually predispose to thrombotic condition. Okay, coagulation profile in particular you want to look for whether it's a normal. Normal is good because you want to start patient anticoagulation later. At the same time, patient can also have isolated prolonged APTT, which may suggest APLS. So next thing, important point to score for this patient is to mention APLS screening, which is the anti-cardiolipin antibody, anti-beta-2 glycoprotein 1, lupus anticoagulant, and also some thrombophilic inherited congenital like protein S, protein C deficiency, antithrombin deficiency, or even factor 5 laden. And then CT brain want to rule out bleed, fine. CTA and CTV is very important because then the confirm is thrombosis, and in particular for CVT, the telltale sign for CTV is actually you get this empty delta sign in the contrasted CT scan. Okay, so you also want to do a CT screening and inflammatory markers checkup. So if you get this diagnosis of CVT and your management, you want to counsel, make sure you mention that management is multidisciplinary approach, focusing on patient education and counseling. And then refer to the eye and the neuro team, initiate anticoagulation. So CVT is also one of the only caveat when you start anticoagulation, despite patient have bleed. But this bleed is a venous bleed. So in the CVT, when you do a CT scan, very common you will see like it's like ICB. So do we start anticoagulation? Yes, we start, because this venous bleed is because of the thrombus bleed. Thrombus that occlude the vessel and causes the vessel to become very fragile and they bleed. But this bleed is not because if you give the anticoagulation, it will not get worse. So this is the only caveat that we will start anticoagulation. That's why it got ICB. So the choice is usually low molecular weight heparin first, then you give warfarin as a long-term anticoagulation. Some can use DOAC, but DOAC evidence is still limited, in particularly for APLS. If APLS is single seropositivity, which is like only like lupus anticoagulant positive, APLA or anti-beta-2 is negative, then yes, there's evidence that you can use DOAC. But let's say triple or double positive APLS, you cannot use DOAC. The evidence is very poor in this respect, and the duration is lifelong because it's this confirmed APLS. So you must also mention patients the examiner likes to hear whatever precipitating factor, whatever culprit drugs, things like that causing side effect or even contribute to the diagnosis, you must stop it. Okay, for example, for this case, you must mention that you want to stop the OCP, refer to the gynae team, and to change to the progesterone base so they won't interfere, even contribute to the risk of thrombosis. And then if patient wants the pregnancy later, yes, but have to go to a proper pre-pregnancy counseling. So you can see that there's a lot of things that you miss in your history and your examination, and therefore you cannot really give a good differential, and everything is affected, including your investigation and your management. But it's a good learning point, I would say. So when you encounter acute headache in exam, in basis exam, so it's also important for you to try to elicit the timing per se. Whether patient present to the ED on the same day, present to the hospital on the same day, or patient came like few days later. So acute headache can be further divided into hyperacute headache or subacute headache. In hyperacute headache, it's the worst headache ever. They cannot tahan. It's very severe. So those are the one like subretinal hemorrhage, okay, or intracranial bleeding, and not to forget pituitary apoplexy. Usually they have underlying undiagnosed or diagnosed acromegaly, Cushing, or platinoma. So this is very important, okay. So SAH, you want to screen for adult polycystic kidney. You want to screen for hereditary hemorrhagic telangiectasia, or is some form of systemic bleeding disorder. ICB patient can have cardiovascular risk issue, can have a trauma, can have a chronic uncontrolled hypertension. Okay, so this three is a hyperacute. Subacute, this patient belongs to subacute. So if you have this approach in your mind, you will really go hit hard on all these subacute causes of headache. This will include CNS infection, meningoencephalitis, or ENT related. Okay, sorry. And then look at this, CVT is very important for you. If it's an infective CVT, then you know that it's okay. Most likely it's not thrombotic. But if it's a non-infective, it's most likely thrombotic. And CVT, sometimes they don't have any true focal neurological deficit. Okay, not always have. Sometimes they may have third nerve, surgical nerve kind of palsy. Can be isolated, can be combined. Sometimes can be don't have, just headache. Okay, can also be vasculitis as well. So you must rule out all the connective tissue screening. Drugs as well, in particular illicit drug you mentioned. Over the counter is also important. And then this can, true enough, this can be acute flare of primary headache. For example, migraine, tension, or even cluster. But the telltale sign is actually, the warning sign is if you have a different character of the headache, and if it's a very severe form of headache compared to the usual headache. So there's a change in the character, as well as there's a change in the severity on top of a chronic headache. So you know that this cannot be the underlying diagnosis anymore. Cannot be just acute flare. You must actually think out of the box to look for something else. And not and sometimes the scenario also came out, which is a posterior reversible encephalopathy syndrome, PRES. PRES, usually a scenario can happen in those end-stage kidney disease on regular dialysis, BP is uncontrolled, and then they will have some seizure. So it can be because of uncontrolled hypertension, or it can be because of PRES, and then they also have severe headache. Headache is part of the manifestation of hypertensive encephalopathy, or it can be because of the PRES. So PRES, you also want to rule out what is the association with autoimmune condition, drugs. In particular, if patient is pregnant, then preeclampsia is also top in the list. And let's say patient got on immunosuppression, is also predisposed to develop this. Okay, so with that, that's the approach of the acute headache. Okay, you have any question, Brian?
No, thank you, doctor.
Okay, I hope you learned something today.
Okay.
So you must keep practice. You must know the approach. The idea is actually everyone knows how to guide a patient in a real life setting, but in exam you need to train your mind to think. You must have approach, some form of approach, some form of recipe when you cook, when you prepare ingredients before you cook, right? It's the same thing. So you must have your own approach when you encounter any form of scenario. The approach for chronic headache and acute headache is very different. So, but this is just for acute headache. Okay. So you can see that every case I go through, there is a certain approach that we want to go through. Okay. So the last scenario is Chua. Chua, are you there?
Yeah.
Okay. Sorry for keep you waiting. I know it's quite late already. So, we will start 4 minutes. Yeah. Your time start now. Okay, time's up. Let's start. So this is the patient, Mr. Smith.
Hi, good evening, Mr. Smith and Mr. John. My name is Chua, one of the doctor in the medical unit today. I received a letter mentioning that your dad been having this dizziness while changing position. Can you tell me more about it?
Yeah, I'm John. So my father have been having dizziness when he tried to change his position. So usually we notice that he feels okay when he's sitting up, but as he start to walk or as he start to stand up, he will feel very dizzy. And there's few occasion that for the past 1 week he tends to fall down. And luckily we managed to catch him on time, and or else he will suffer from a very serious injury. We are very concerned, doctor, about this condition.
Your concern is very valid, Mr. John. Let us ask you a few more questions. Is
Hmm.
this how long, apart from this 1 week, does it have similar episode previously?
1 week before, no.
Also, this is something new and it be ongoing for 1 week.
Yes.
So the posture changes only limit to sit up to standing, is it? How about when he's lie flat, then he wake up, then he try to sit or stand? Do you feel
Yeah.
dizziness?
Yeah. In the morning, if it's from lying position to sitting, yes, he will also encounter.
It only happened in the early morning, or it happened throughout the day as well?
Actually, throughout the day and night.
Throughout the day, sir. I see. Um. Okay, sure. Did he felt any part of his body having weakness?
No.
Weakness. Any blurry of vision?
No.
Any issue with in passing urine?
No.
Any heart beating very fast?
No.
Okay, sure. No problem. Did he notice his skin to become more darkened recently?
No.
Okay, sure. Did he feel excessive hunger, or he feel like thing before the dizziness?
No.
Okay, 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 sure. Okay. Did he ever encounter any nauseatic feelings, vomiting, only loose stool?
No.
I see. Sure. May I are you going to ask you a few more questions? Did your father ever fainted?
Fainted? Not really.
Not really. Any abnormal posture you notice over the hand or the legs?
No.
Okay. Does his movement appear to be fast or slow to you?
I feel like he appears a bit slow nowadays. He also say that he feel easily tired throughout from the day and night. And then for that reason, I think he's not drinking that much. His appetite has been reduced as well.
I see. Or appetite be not doing good. How about his body weight? Did he lose a lot of weight recently?
We didn't really check for the past 1 week, but I presume maybe there is because he wasn't drinking much or eating much.
I see. I see. He must be worried. Let me ask you. Let me help you throughout the process. Does your father complain of the dizziness when he turn his head posture?
Head posture. I mean, turning the head will not cause the dizziness per se.
Okay, sure. No any hearing impairment, yeah, or hearing
No.
like. Okay, sure, no problem. Does your father afraid of afraid of cold environment?
No.
Okay. Having any problem with passing motion?
No.
No constipation?
No.
Okay, sure. Okay. May I know that do your father have any previous medical condition previously?
He have multiple condition. He have diabetes. He have long-standing kidney problem, and he also done a few surgery before. He got cataract surgery done, and then recently he also went for his knee replacement surgery
Mm. Recently went for knee replacement surgery. How recent?
about 1 week ago.
1 week ago. Oh, okay. How's the surgery? Any complication?
No. He was like a 2 days kind of history. 2 days kind of hospitalization. So he have this left knee pain. The doctor told him it's because of the old age. I suppose it's because of the osteoarthritis. And then the bone doctor went in to do a knee replacement. And then he was discharged well the next day at home.
Did he take any pain medication for the joint replacement surgery?
Yeah, in terms of the pain medication, he did take some tramadol and also serum morphine as well.
I see. Does your father ever pass out blackish stool?
Oh, no.
Okay. So I see here there's a few diabetes medication. How's your father diabetes control?
Diabetes control was okay. The doctor told him that his 3 month sugar control was actually about 8% at his age.
I see. I see. I saw your father been taking blood pressure medication. Have you ever like checked his blood pressure regularly at home?
Yeah, we have been checking regularly before that. But recently we noticed that his blood pressure is like borderline 110. Behind the reading is about 60 to 70s.
I see. Any new medication added on this list of medication recently?
No.
Oh,
The
okay.
new addition is just the painkillers and some neurobion. That's the new addition.
Your father complained more and more thirsty, required to drink more water, and went to toilet recently. Drink more water, and he required to go to toilet at night recently more. Yeah.
No.
I see. Any numbness over the hand or feet?
No.
Okay, sure. Okay. Does your father have any allergy?
No.
Any of your family member encountered similar complaints previously, like dizziness or changing postures?
No, before that, actually before the surgery, my father is a very fit person. He can walk, just a bit of knee pain, lah, but he can take care of himself very well. He never have any issues. So this thing is something very new to us and for himself as well.
I see. Sure. Okay. Just to clarify again, no chest pain, no short of breath, um, no beating very fast.
Yeah, no.
Okay, sure. May I know, does your father smoke?
No.
Does he ever drink and consume any alcohol?
No.
I'm going to ask you a few more sensitive questions, which I'm going to ask all of my patients. I hope you don't mind it. Sorry. Do you know that your father had been taking any party drugs or?
Oh, no. He don't do that.
I see. Sure. Did he travel anywhere recently?
Travel, no.
I see. May I know, you've been saying that he's been losing appetite. May I know that how's his appetite recently? What's he been taking recently?
Yeah, he only takes some porridge most of the time. He cannot really eat like what he used to.
Do you check his sugar at home as well? How's the sugars?
Yeah, the sugar is always now for the past 1 week he has like between 5 to 8 like that.
5 to 8, huh? Okay. Did your father ever take any over-the-counter medication, or he bought himself any medication previously?
No.
Like,
This is all the medication that he takes. He don't take any other medication.
okay, I'm going to have a look at Mr. John. Is he all right, Mr. Miss?
Yeah, sure.
I offer to check a postural standing line BP for this patient to look for any postural drop in postural hypertension.
Yep. So the standing blood pressure for this patient is 83, 32. The sitting blood pressure is actually 100 and then 75.
See, I would like to check the DXT as well.
The sugar bedside, if when you request, is actually 5.2.
I'm going to do a general inspection of this gentleman. Is the patient hyperpigmented, or is there any masked faces, hypomemia, or yeah?
No.
I'm going to introduce myself to the patient to look for any hypomemia.
When you check the patient, patient have no reduce in eye blinking.
Okay. Okay. No reduced eye blinking. I'm going to check the patient gaits. If he able to walk and stand. Yeah.
I mean, examiner say patient cannot walk because of dizziness. You can skip this.
Okay. Sure. I'm going to check the patient general tone. Is it hypertonia or is it rigidity going on for this patient?
No hypotonia, no rigidity.
Hydration status for this patient, is it well hydrated or is it like under volume?
Hydration status is on the lower side. When you check the capillary refill is about 2 seconds, and then the pulse volume is just moderate.
Okay, sure. Is the patient pallor?
There is mild conjunctival pallor.
Conjunctival pallor. Okay, sure. Okay. I'd like to check the patient for any nystagmus over the H test and check for the cytosol kinesia and the symmetrical test, the finger to nose
So,
test.
okay, one by one, you check for any nystagmus, no nystagmus. Patient seems difficult to do this kinesia. You can skip that. But finger nose test is normal.
Okay, I'm going to check on the patient the truncal region. Is there any striae noted? Is there any
No
like
striae. No.
or okay. No skin tanning, no bruises.
No. 2 minutes left.
Okay, may I know what's your concern, Mr. Smith and Mr. John?
Yeah, doctor, I'm very worried. What happened to my father? What is wrong?
Okay, Mr. John and Mr. Smith, but we are still trying to find the exact cause for your father. Why is he feeling dizziness when he's changing posture? But there's a few things that I'm thinking maybe it's actually due to the complication of the uncontrolled DM. Sometimes you have long-term uncontrolled DM. Actually, it might affect how your body nerve works. So yeah, it might be one of the cause, but I need to do a few more tests to confirm it. Once I confirm it, I will get back to you as soon as possible. Is it all right?
So sorry, what is the cause?
It's what we call a diabetic autonomic function, autonomic dysfunction. It's one of the cause of when you have uncontrolled diabetes or long-standing cause. Yeah, so I need to do a few more tests to find out the exact cause of it. I mean, other cause maybe he's not really drinking or eating well, so causing him his body fluid being depleted. So not enough. Yeah, but I'm still thinking the complications. But I need to find out other cause as well for the patient.
Okay, and then can this be due to strong painkillers that was given after the surgery?
Actually, it's possible. It's possible, but usually the strong painkiller wouldn't cause the dizziness upon changing posture. It's more like a throughout, whether you change, whether you sit or whether you stand, usually the dizziness will be there. This is what is usually like if it is caused by the painkiller. But I still like to work out it further. Yeah, it's one of my list.
Okay. Does he need admission?
Yes. Just now when we checked your father blood pressure when he's standing, it's actually quite low. It's lower than the normal people. So and he seems to be slightly volume dehydrated. So we admit to the hospital. We give him some fluid through the line, and then we work out the cost for him. And we try
but-
to work out the
But
cost.
doctor, he keep on telling me he don't want to be admitted.
I see. Is there any particular reason why he don't want to be admitted?
Yeah, he said he don't like hospital. Is there any chance that he can be treated as outpatient?
I would not recommend it. Maybe I talk to your father, then I might be able to convince him to stay in hospital. But as I say, if he really doesn't want to stay in hospital, maybe we can offer outpatient service. I mean, outpatient doctor service. I go to his house to have a look on him. Is it all right?
Okay. Is his condition reversible?
As I say, the now the cost is still we are still looking out for the cost. So it very actually depends on the once I found the cause and the cause is treatable, the condition might be reversible.
Okay. All right. Hands up. So, can you go through the list of differential diagnosis and the provisional diagnosis for this patient?
Actually, my provisional diagnosis for this patient, I was thinking maybe this patient actually have a postural hypotension due to hypovolemia, but other cause including adrenal insufficiency, diabetic autonomic dysfunction, Parkinson plus syndrome, drug-induced causes, especially on alpha blockers, hypoglycemia or
Sorry,
hypovolemia.
what? There's no alpha blocker, right?
There's no alpha blocker. Yeah, there's no alpha blocker. Yeah.
Yeah. Then the
Yeah.
justification for the drug induced.
I'm trying to find out whether there is, but there's none there. There's none there. I mean, apart from the painkiller, the tramadol and morphine, but I don't find any alpha blocker there. And
But
he don't
there is something else that can also cause the blood pressure to be low, right?
the dapagliflozin, the
No, it's not dapagliflozin.
parentopil.
Yeah, parendopil. Dapagliflozin can hardly cause any hypotension. It's not significant at all. But parendopil is important. Okay. Anything else to explain the hypotension?
The poor orienting, but otherwise I can't find any causes.
You mentioned hypovolemia, right? That is also one of the same explanation. And any other possibility?
Any other possibilities? I need to ask about the urine output, whether does it have any polyuria due to the uncontrolled DM?
You asked already, actually. You asked already, which is not.
Yeah, which is don't have. Yeah. But I do ask about GI losses as well, which is don't have. I'm not sure actually. Yeah.
Okay, never mind. How will you investigate this patient?
So first I will do the ABC. So I will double check the patient postural hypertension in the ward a few times. Then I will check the patient according to my list of investigation, the AM cortisol or short signaling test for adrenal insufficiency, diabetic autonomic dysfunction, HbA1c level will be good. Otherwise the drugs, right? Hypoglycemia, check the DST, the range. Other causes including no.
Did you mention Fulberg picture, Fulberg count?
Yeah, Fulberg count to look for anemia, but this patient does have some mild conjunctival pallor.
Right.
Yeah.
How about the any anemic workup?
Iron study, PBF, B6, B12, B1.
Okay.
But this patient is a non-alcoholic consumer with B6, B12, iron study, anemia, LDH, PBF.
Okay. I mean, what is your different? You mentioned a few differential, right? You want to exclude them?
Yes. So actually, most of them are trying to exclude already. AI, yes. Diabetic autonomic dysfunction, yes. Parkinson plus clinically doesn't seem like it. Drugs, I look at the drug, it doesn't seem like it. Hypoglycemia, no. Then hypovolemia, no. Anemia, there is some trace of it. Then I do screen for cerebral symptoms as well, which the patient doesn't have any cerebral syndrome.
I thought you mentioned adrenal insufficiency.
Yeah, adrenal insufficiency. And cortisol and short.
You want to do what? Sorry?
And cortisol and a short selected test if there's adrenal insufficiency for this patient. Or even
Okay. How will you manage the patient?
It actually largely depends on the cause that I found. So now I'm thinking more towards hypovolemia. So I'm trying to hydrate the patient till euvolemic. Then I work out the other cause. I try to off the offending medicines. Then followed by the causes that I found. If let's say this patient do have some points of adrenal insufficiency, I provide patient with steroid replacement. Otherwise, patient counseling and patient education to counsel regarding diet, so patient have better DM control. Anemia as well. I try to find out the cause of anemia for this patient, which I will offer OGDS and colonoscopy for this patient to rule any malignancy in this case. Then I also will offer hematinics for him.
Any non-pharmacological things that you can advise?
For the dizziness and fall, so I want patient to be all the time accompanied by his family members. So
Okay,
don't
time's
walk,
up, but you can continue.
don't walk when he feel dizziness, and then if he ever have a high risk of fall, so I will nurse the patient on beds. Then
Okay. So to cut the story short, you're talking about career training and supervision. Okay, just forwards only.
Okay.
What other things, non-pharmacological things that you want to offer?
Housing modifications, not
Okay. Again, OTPT, home
Yeah.
modification. Okay, anything else? More
Diet.
important thing.
Diet control.
Okay, can anything else?
Anything else?
You're not hitting the main dish for postural hypotension, non-pharmacological intervention. So usually how you so-called reduce the symptom of postural hypotension?
Is the
Other than addressing the
Is-
cause,
other than
supportive. What was the supportive things that you can offer?
test stocking. Test stocking
What
for you.
head stocking?
Test stocking maybe. To
But
bring
test
up the
stocking is more like preventing
Yeah.
the VTE, right? Thrombosis, right? Something similar but not TED. It's actually the calf compressor, and also abdominal binder. Okay, so these two can actually promote the venous return and reduce the fluctuation in the BP. So another thing is, how about the pharmacological intervention for this postural hypotension? Any medication that you can offer?
Fluorocortisone and the
Okay, another one.
another one start with M. I cannot remember.
Okay, yeah, midodrine, right? Yeah. Okay. All right. So, how would you think about this scenario? What is your comment?
How do you tackle the AI symptoms in this patient?
Sorry, what AR symptom?
How is this patient, the cause? I'm not really sure about the cause. But then our discussion is more towards adrenal insufficiency. But then I didn't really
No.
take.
I actually, my discussion actually did not direct to anything. It's just that because earlier you mentioned about adrenal insufficiency, that's why I'm asking you, do you want to include that under a differential? So sometimes you don't have to be very, very worried if you don't have any specific diagnosis in terms of etiology, because sometimes it can be multifactorial. A lot of things can contribute to the single diagnosis. You see, you don't have to force yourself to choose between like five, choose between one. No, you can say, I think the patient have a postural hypotension and the cause likely multifactorial, because from the history examination, I noticed that patient has is actually under volume, has hypovolemia because of the poor oral appetite, as well as supported by my clinical examination finding. And it can also be due to anemia, as evidenced by conjunctiva pallor. And at the same time, patient can also have some form of adrenal insufficiency post-operation, which is common in his age. And at the same time, patient can also be due to drugs-induced factor, for example, continuation of the blood pressure medication despite the blood pressure is already borderline at home. At the same time, also taking analgesia, including opioids. We know that opioids can also cause some form of postural hypertension, especially in elderly. Okay, and I won't even mention about Parkinson plus, because the patient have no features to suggest Parkinson plus.
Yeah.
No rigidity, there's no bradykinesia. How can suddenly patient develop MSA for unknown reason, right? So I won't mention that. But autonomic dysfunction because of uncontrolled diabetes, yes, possible. Can be autonomic neuropathy from uncontrolled diabetes. So I mentioned all that. So you see, you don't have to force yourself to come up with one single unifying diagnosis, because sometimes the cause is multifactorial. It's just that, for example, a case of chronic diarrhea, patient have multiple possibility, like for example, maybe it's got some gluten intolerance, you think it's celiac disease. At the same time, patient is very young. Patient also got some form of IBS, very stressful in life. So you see, a lot of times you don't have to commit to one single diagnosis. You just put that most likely diagnosis maybe can be, for example, it can be celiac disease. However, I do realize that patients is also have a lot of things going in his or her mind, have encountered a lot of storms in the sense of life. So it can also be some form of irritable bowel syndrome after extruded organic cause. So you have to mention that. Okay, so sometimes you don't have to force yourself to choose one. This is number one. Point number two is your history is okay. You managed to get most of the thing, but I realized that you still require a bit of prompting. If I don't prompt you about the surgery, I give you because if you ask about medical history, I won't. Sometimes we don't really need to mention surgical history at all. So certain surrogate very good. They will tell you medical history and surgical history. And sometimes when you ask, do you have any medical problem in the past? They will just tell you medical history only. So you must really ask specifically for surgical history. And another thing is that I think your history is fine. Your examination, basically, I can't remember what you examine already. You examine for the hydration status, postural BP. What else? I can't remember what you examine already. In terms of examination.
Anemia, then I try to find for
Oh,
Parkinson.
anemia. Yes, anemia and the Parkinsonism rigidity. Anything else?
Cerebral sign, and
Cerebellar sign. And then the Cushing thingy that you want to exclude, right? Or hyperpigmentation or something like that to want to rule out adrenal insufficiency. Okay, fine. I think it's okay. The thing is that for this patient, right? Let's say you're thinking this is an uncontrolled DM. Perhaps another thing you want to do is actually offer fundoscopy to look for any retinopathy. Another thing is to really offer to do a pinprick test to check for any peripheral neuropathy. A lot of people, they just very stressed with exam, very focused. So, but if you're thinking more to uncontrolled DM, diabetic autonomic neuropathy, right? You need to justify that this is an uncontrolled DM that already have some form of end organ damage. So, meaning to say you have to at least put a few points of the usually in exam they will give you the fiber lah for to check the pain sensation instead of the pinprick. So the microfilament fiber is the one that usually you can just try a few points just to elicit whether there's any peripheral neuropathy. In this condition, in this patient, actually is quite important because you want to sell the diagnosis of uncontrolled diabetes with autonomic neuropathy, right? So that's why it's important. Under your investigation, I feel that you're not very focused. And one of the things that I calibrated that I expect you to mention because of the low volume status is to really check for AKI. You didn't mention anything about kidney function, BBG. You didn't mention about checking UFAM, you see, or screen for any UTI. Post-surgery, how common elderly get a UTI? It's very common. So again, all this thing is also contributing, okay? So you must also think as a whole. Another thing is that I realized that you want to offer OGDS and colonel to screen for anemia, which I disagree because the patient, the son told you that before this, he's very well. He had no issue. He got no dizziness at all. It's just after the surgery, he have issues. So the anemia, if let's say present, is most likely because of some form of post-operative blood loss. Okay, you are not thinking about something like chronic anemia. But yes, let's say it's persistent, then you may need to do a scope. But before doing a scope, you can actually offer to send a stool or count blood test. If it's positive, then maybe you can consider sending. So I don't see a rush to really go in for a scope for him because got hypotension and all those things. You see, the idea of exam is try to make yourself to actually sell yourself as someone who is safe to practice and who is also thinking of various aspects as a whole. So not just targeting an anemia. You also need to look at the patient as a whole, whether patient really got any active bleeding and whether this anemia is something acute or chronic. Okay. So another thing is that, your management part, because you're a bit confused, you don't know which direction you're aiming, right? But to me, even if you're not sure of diagnosis, at this point, make sure you review back the medication, especially elderly. Elderly always got this polypharmacy, and a lot of times when they're unwell, you need to adjust. Metformin will you continue in real life or not in this condition?
No, I off it. Yeah.
But you didn't mention in exam. Okay,
I-
number one. Yeah, perindopil, will you off it in real life when the BP is low?
Yes, yes.
Yeah, but you didn't mention also in the exam.
Yeah.
And tramadol, morphine, is a patient not in severe pain, will you off it?
Yes.
Yeah, so you see, it's important to adjust the medication, to stop some medication. So all this is also part of management that you need to mention. It's not just enough like, targeting anemia transfuse, for example, adrenal insufficiency, subhydrochloride. Oh, it's not just enough to mention about that. The examiner don't want to listen all those things that they definitely know we all going to mention. The examiner actually wants to know that how are we going to care about this patient in real life. So you just don't have to be very exam oriented. You say that, okay, our management, right? My management for this patient with multidisciplinary team approach, focusing on patient education, counseling, and a referral to our dietitian, our occupational therapist, our physiotherapist, our speech, who else? For example, in this case, depending on the condition, I will also get involved into other discipline for co-management. But to begin with, I will review back his medication. I will stop metformin. I will stop analgesic if it's not in too much pain. I will stop his antihypertensive, and then I will observe. And then I will assess his response. I will hydrate, start the fluid. I will start IV drip to hydrate the patient, and then we may need to transfuse if the HB is very low. And then let's say I take a cortisol result. AM cortisol is very low, suggestive of the adrenal insufficiency, and may start the patient on the hydrocortisone replacement. And at the same time, in regards to the postural hypotension, non-pharmacological measure, I can start the patient on calf compressor, can start the patient on abdominal binder, counsel on the risk of fall, carrier training, everything that you mentioned just now. You don't have to lie too much. You just mention, because you only got 5 minutes. Management usually you only got 1 or 2 minutes, so you need to budget your time. So you just mention about carrier training. You want to mention about home or environment modification can. You want to mention all those not so important thing can. But you need to mention about pharmacological part of this postural hypotension. If let's say it still persists despite adequate volume repression, then you really need to consider starting patient on mimidone, or even, for example, fludrocortisone. You see, so this way, if you present this way, it's more natural also, right? You're not like just exam based, just targeting the exam. So sometimes the examiner likes to hear our answer that is a bit more lively. I would say lively in the sense that we're not so template. Like, I will do this, do that, do this, do that. But you are just looking at the patient as a whole. This is a postural hypertension, can be a lot of cost. So you target one by one, and then you offer. So you don't have to be very rigid. What I want to say is actually in exam you can try to make it very diverse, make it very more flexible, and then it's depend on how you want to present it. My way can be different than uh, other examiner, other consultant ways. So there's no definite way. The idea is to get your things that is more comfortable with you. So do you know any special condition like post operation with some patient with risk factor like elderly, or undergo some form of GA procedure? They suffer from postural hypotension. Do you know any condition in relation to this?
No, I don't know.
Yeah, so actually there's this it's also one of the postural hypotension. It's actually a subtype of postural hypotension. What we call actually as a POTS, or post-operative orthostatic intolerance syndrome. So POTS is actually quite increasingly being recognized nowadays as part of the ERAS. If you know what's ERAS, right? Do you know what's ERAS?
No.
No. Oh, you're not close with your surgical colleague, is it? Always fight with each other in referral. So nowadays surgical not even nowadays, actually for the past 10 years has been there for some time when we are still medical student. So it's just that not being widely practiced. So in surgical, their concept is actually early rehabilitation, early recovery. So they are trying to things like, for example, transfusion. Also, they want to give things like judicious transfusion, so they are doing things to enhance the surgery peri-operatively, can be pre-op, intra-op, and post-op. So one of the component in ERAS, or what we call as enhanced recovery after surgery, is actually to recognize this entity called POTS, which is a post-operative orthostatic intolerance syndrome. Most likely the patient can have, the risk factor is actually the elderly. Usually it's elderly age group with multiple comorbid, and usually they have underwent a GA procedure, a long surgery with some opioid use. So all these are risk factor to develop this. So the management is actually supportive. Make sure that hydration is good, and at the same time consider non-pharmaco and pharmaco intervention like what we mentioned just now. Okay, so it is, to be honest, does it make a difference if it's compared to postural hypertension? It's not. It's the same. It's the same thing. It's just that this is a very new entity that actually came out. In fact, the reason why I'm discussing this case because one of the center in the international level actually came up with this diagnosis before in the recent years, in the recent 2 years. So I think it's also important for everyone to recognize this entity. And then the rest of it, I think everyone can look through. It's almost the same. So what is the cause of postural hypotension? My question to you. You have mentioned a lot, but how do you remember in exam, and whether you will screen everything, without missing anything?
Oh, I don't have a fixed mnemonics.
Yeah, don't really have to have fixed mnemonic lah. But then but I think what you go through is fair. You have go through anemia, adrenal insufficiency. Okay, you go through drugs, dehydration, or so-called hypovolemia. You also have go through autonomic dysfunction. So this is actually all of it. So the way that I remember in exam, I just put D and A. I remember I got 2D and 3A to kind of like screen through. So the drug is actually, that's why the first cause of postural hypertension to me, right, also in exam as well, is drug induced, very common. So it's important for us to also target the drugs, okay, whether we need to review back the medication, to change it, to stop it, things like that. And then drugs that include antihypertensive, not only alpha blocker, but any form of antihypertensive, diuretics, and also opioid. So this patient got 2 already lah, huh? In fact, got 3, got 2 lah. And then dehydration, yes, because this patient is under volume, dehydration can also be cause of some other reason for infection, for example. So under dehydration, you also need to rule out whether patient has some form of infection. So therefore, you also need to work out on that. Anemia, you also need to rule out whether there's any blood loss, in particularly acute or chronic blood loss. Adrenal insufficiency, you must also think a bit deeper. Can this be primary or secondary adrenal insufficiency? And if let's say the adrenal insufficiency somehow related to some hypothyroid syndrome, you may want to also thinking that can this be some form of autoimmune polyglandular syndrome? It can happen as well. So usually either grave or Hashimoto, underlying stable, then came in postural hypotension. So first thing you want to diagnose is actually, can this patient have adrenal insufficiency? The second question is, can this is actually autoimmune polyglandular syndrome in association with underlying autoimmune thyroid disease? Okay, so the last A is actually autonomic neuropathy. Yes, it can be due to autonomic neuropathy, diabetic autonomic neuropathy. Can be due to alcohol, can be due to CKD, amyloidosis. We know that cardiac or even like systemic amyloidosis, they also can have a very early manifestation of postural hypertension. So this is something that we can offer as well in those patients with, like, for example, CKD. This patient also can offer actually, but just that the history is very short duration, only 1 week, not really got any long-standing postural hypertension. So MSA or advanced PD, not only Parkinson plus, patient with Parkinson disease with advanced stage, usually they also can have some form of autonomic neuropathy as well. And don't forget neurosyphilis. Neurosyphilis can also present with autonomic neuropathy. So these are the things that you need to screen through, especially you encounter a case of postural hypertension. Okay?
Thank you.
Any question?
No.
No, I think everyone is clear, right? Anyone have any question?